Good afternoon. Thank you for
Good afternoon, Madam Chair.
Good afternoon, Senator Kramer. Thank you for coming to the Senate Finance Committee. Today's Wednesday, February 12th. I'm Senator Pam Vital, the chair of the committee, and with me is my vice chair, Senator Antonio Hayes, and the rest of the committee members welcome you. Sponsors, when you come to the table, you can have all the time you need. Your panelists, your witnesses can have 2 minutes. Please honor that. You see a lot of spaces missing today because people on other committees doing testimony, just like we have the vice chair of JPR with us to do testimony. So his seat is empty in JPR. Senator Ross-Stryker, would you like to come and present Senate Bill 411, please? And you have one panel member, Ariel Juberg. Thank you.
Well, thank you, Madam Chair, Mr. Vice Chair, members of the committee. I know this committee does a lot of important work when it comes to health care, and it's complicated work, but if we had to reduce it to a simple axiom, it would sound something like the following. What doesn't get billed doesn't get cared for. And each of us has seen this in our own lives. I've got kind of a very minor story, but I'll tell it. Some of you know I have Crohn's disease. I see my gastroenterologist twice a year. And once a year, it's a real thorough examination, a whole workup. And the other time, it's just a quick check-in, like a 15-minute conversation. And I asked him once, this was pre-COVID, like, can we do this over the phone? Is there, like, nothing's really happening in this second appointment. He's like, no, I really need you to come down. And so I'd have to schlep up to Baltimore, and sometimes I'd need to get childcare, and I'd have to miss work, all for a 15-minute conversation. But since COVID, because of the laws that this committee passed, now we just do a quick phone call. Why the difference? It's not because he really wanted me there for that appointment. It's because now he can bill for that time in a way that he didn't used to be able to bill for that time. And so I think that's an important lesson. And so that brings me to Ariel Juberg, who you're going to hear from in a moment, and the much more serious issue that she faced with postpartum depression, which is sometimes a life-threatening issue. And you'll hear from Ariel, and she's got a dramatic story to tell, but as I'm finishing my testimony, if you want to hear more about Ariel's story, I encourage you to look at her op-ed in Maryland Matters. Her last name is spelled J-U-B-E-R-G if you want to just Google it. But let me set the table for her testimony. All of our major insurers, including CareFirst, absolutely do cover postpartum depression. But the condition is fairly unique because after the birth of a child, mothers are often dealing with medical professionals with less expertise in the condition. And so if a new mother knows she is suffering from postpartum depression and makes an appointment with a psychologist or a counselor or a psychiatrist or a therapist or any other mental health professional, of course those professionals know that their services will be covered and they will be reimbursed. But oftentimes, new mothers describe very serious postpartum symptoms, not to mental health professionals, but rightly and logically to the two doctors with whom they are interacting most frequently after giving birth, their OBGYN or their baby's pediatrician. And in many cases, and you'll hear this today, these professionals only provide perfunctory care in diagnosing, treating, or referring out serious postpartum depression cases. And it's not because those professionals are incompetent or uncaring. It's because OBGYNs and pediatricians don't realize that they are allowed to bill for their time to take care of new mothers. So Senate Bill 411 changes that. It's like a bat signal to all our providers. No matter what type of doctor or health professional you are, no matter what context you encounter a new mom with postpartum depression, you will be reimbursed for the care you provide. What doesn't get billed doesn't get cared for. I ask that you take a moment to hear from Ariel and pass Senate Bill 411 favorably. Thank you, Madam Chair.
Good afternoon, Finance Committee. My name is Ariel Juberg. I am a Baltimore County mother. I urge a favorable report on Senate Bill 411. We're 2 days away from Valentine's Day. That day usually brings good feelings, whether we're celebrating with a significant other, getting a Valentine from our children, or simply gazing at the chocolates in the grocery store. but 2 years ago on Valentine's Day, I had one of the lowest moments of my life. I watched my husband play with our then 3-month-old daughter, and I thought to myself, they would be better off if I wasn't here anymore. I cried most days. I felt uneasy and on edge, and I believed things would never get better. By Valentine's Day, I had taken my daughter to her pediatrician 7 times in her life. At those visits, I completed the postpartum survey honestly, disclosing my dark thoughts and my hopelessness. And to my surprise, the survey was never mentioned by the pediatrician. After a few visits, I started refusing it. I'd also been to my doctor for a postpartum visit, and the nurse midwife glanced at the survey that I'd completed and moved on with the visit. In the midst of interrupted sleep and daily care for a newborn, I didn't have the strength, the time, or the fortitude to diagnose myself and to navigate our labyrinth of a healthcare system. The providers that I saw weren't necessarily aware that they could be reimbursed for reviewing the information with me. So the first thing that we can do to tackle this problem is to ensure that all providers know that they can be reimbursed for this service. If we value maternal mental health, let's make sure that providers know they can be reimbursed for a life-saving service. Thank you.
Thank you for your testimony. Do I have any questions for the senator or the witness? Seeing no questions, we appreciate the bill. Thank you.
Yeah. Good afternoon, colleagues. Next, we're going to hear Senate Bill 406, which is sponsored by our chair, Senator Bidle. On the chair's panel, we have John Edward Heath. As I call your name, please come to the table. Cheryl Sachs, Matthew Mitchell, and Jonas Lejeune, I'm guessing. Young? All right, thank you. See 3 people. Am I missing one person? John? Who's John? Okay. All right. Cheryl. That's Cheryl. Matthew and John. Okay. Of course.
Mr. Chairman, Vice Chairman, and members of the Finance Committee, thank you for the opportunity to present Senate Bill 406. You may remember last year we passed a bill so everybody can move, and remember our little guy Nathan, who I think stole everybody's hearts, and we passed the bill so that Nathan can play baseball, which he's doing very well. I was talking to his grandfather the other day. So the bill we passed last year really helps not just children like Nathan, but people that want to be involved in sports that have a prosthesis. What we did last year to get the bill through is we agreed to take out orthotics. And so this bill this year just puts the orthesis back out. Hopefully we can get it passed for commercial insurance and Medicaid coverage. Orthosis or orthotic devices are external brace supports to treat a congenital neuromuscular musculoskeletal disorder or acquired condition. The bill matches the coverage and language of the prosthetics bill, which unanimously passed the Senate last session. Under the bill, Medicaid must expand its existing coverage to include orthosis for the purpose of participating in certain physical activities related to whole body health, such as swimming and running. Medicaid currently covers 370 orthotic codes, L codes, for which utilization is expected to increase under the bill. The disability community is at a significantly higher risk of physical inactivity when compared to their able-bodied peers. 50% of the adults with disabilities get no aerobic physical activity, and the prevalence of obesity in children with mobility impairments is twice that of children without disabilities. This legislation will change lives, just as it did Nathan's, and significantly decrease costs associated with the significant comorbidities associated with the physical inactivity, diabetes, and cardiovascular disease, just to name 2, with a small upfront cost. Please note that the fiscal note is based on the cost study completed by the state, but multiple billing codes included in the calculations are not relevant for this bill. The advocates who you will hear from shortly have already met with MDH, who's working to revise their calculations. Together, we can ensure that Marylanders have access to medically necessary custom orthosis for physical activity. I respectfully request the committee for a favorable report on Senate Bill 406. Ready?
Good afternoon, Mr. Chair, members of the committee. My name is John Edward Heath. Most of you guys remember, if you don't know me, I'm a retired Marine Corps Staff Sergeant, local Annapolitan. I'm a retired professional athlete. Most importantly, I am an individual who used this kind of device prior to my amputation. Without that device, I don't know if I would be sitting here having this conversation and advocating for the disabled community in Maryland. There is a huge psychological factor when it comes to whether it's limb salvage, whether it comes to amputation. The biggest advocacy for me, honestly, is just the fact that we are the forefront of this movement in the state of Maryland, and I genuinely think that we can be the blueprint for the rest of the country. We've had 4 individuals already get their prosthesis from what the media is saying through the law that we changed that went into effect January 1st. So as an individual who used a device that the device was created to return back to service, it was created in 2009 for limb salvaged individuals to return, whether it was in country or to serve their everyday job in service. I was one of those individuals. So I had a limb salvage for 6 years. Unfortunately, my situation was way too extreme and I opted for an amputation. So just being the subject matter expert of using both devices and knowing the psychological benefits and just the positivity of what you can achieve with something as simple as an orthotics device, it's my job to advocate for the citizens of Maryland for that. So with that, I urge everybody to take into consideration that what we did has a massive impact in the state of Maryland, the disabled community, but can also have a bigger impact if we include orthosis in that. Thank you.
Mr. Vice Chair and members of the committee, my name is Cheryl Sachs, and I thank you for the opportunity to comment in favor of Senate Bill 406. I am a certified prosthetics and orthotics practitioner who provides care for patients and have been doing so for over 13 years. This legislation would be life-changing for some of my patients and allow me to provide more appropriate medically necessary patient care. With this legislation, Maryland can continue to change the way we view individuals with disabilities. This bill is about more than a device. It is about what that custom device has the power to do, to give individuals the ability to live their lives like their able-bodied peers. My patient who needs a rigid custom orthosis for walking, but a more dynamic custom orthosis for running, playing sports, and weightlifting, will no longer have to hear that being physically active, according to his insurance, is not medically necessary. One device for some patients is not enough alone to replace what the human body can do. Last year, Maryland became the 6th state to pass legislation as part of the So Everybody Can Move movement, and Maryland is one of 9 states to have introduced legislation since the new calendar year. The reason for this widespread success is simple. These bills are low cost with a huge social impact for people with disabilities. This legislation is designed to modernize outdated insurance policies and remove barriers that prevent these individuals from living full, active, healthy lives. Ensuring access to custom orthoses for physical activity not only promotes this healthy living and independence, but upholds the responsibility of health insurance providers to serve the public interest. This bill is about more than coverage. It is about fairness, dignity, and the fundamental right to movement, so that parents will no longer need to explain to their children that insurance says that they do not deserve to live as healthy or as active lives as their friends or siblings. We understand that you need to make a lot of tough decisions this session, but this is an easy one. This bill is an investment. It is an investment in your constituents and an investment in the physical, social, and mental health of the disability community, children and adults, their families, their friends, and their larger community. So as you consider this bill, I urge you to consider the overwhelming positive impact it will have on your constituents and understand that the costs to do so are significantly overstated. Thank you.
Hello, Mr. Chair, Vice Chair, and members of the committee. I'm here to share my story. My name is Matthew, My story starts with a fracture to my L4 vertebrae on my spine, causing life-changing damage to my body. I woke up in the hospital completely unable to move my left leg or foot. Couldn't wiggle a toe. Came with immense pain I couldn't escape. After 2 weeks, I stood for the first time by clenching the walker with all my strength. 8 nurses crowded around me, helping. I stood shaking for no more than 15 seconds before collapsing back on my bed, drenched in sweat. The bottom of my feet felt like rubber, and I was frail. Then gradually working my body by standing and sitting, I finally, after a month in the hospital, could take 15 steps with a walker and an assistant before being completely depleted physically, with jolting pain from my back down my right leg from overcompensation. Over the next 2 months, I walked every day no more than 8 parking spots in a parking lot. 8 forward, 8 back, that was it. Too embarrassed to be using a walker, I prematurely started using a 4-prong cane. That's when I met Charlie, my orthotist. And soon after my first non-custom AFO, it was fantastic. I could now walk with a stiff brace to help my drop foot and make it a full mile. However, in excruciating pain, after lots of practice with the non-custom AFO, I gained more and more. After 4 months of the non-custom AFO, it was recommended I receive a custom AFO because it had far better capabilities to further my progress. After receiving my new custom AFO, I went from mustering 1.5 miles max to quickly 5 miles in one trip, slowly taking on hills, to weeks later making it a 7-mile hike, to being able to enjoy a day trip and walk 10 miles around New York with my father, to my new personal best, a 12-mile hike with parts of it on a beach. With the right custom AFO, I would have the ability to run again, but if I try to run in my current AFO, it would break, leaving me unable to walk. The only thing preventing me from being as physically active as I was before my injury is a lack of insurance coverage. My incredible progress is owed almost entirely to the custom orthotic and my orthotist, Charlie Kelly. Please help me continue my recovery by passing the Senate Bill 406. Thank you.
Good afternoon, Chair, Vice Chair, and Finance Committee. Thank you very much for hearing our stories today. My name is Jonas Young. I'm a clinician similar to Cheryl. I've been working in the field for about a dozen years, and I treat patients with both prosthetic needs and orthotic needs. I kind of wanted to speak from a personal space, and I'll also thank everybody for their support for the So Everybody Can Move prosthetic bill, which was passed last year. Orthotics and prosthetics is about restoring function and ability to our patients who we see every day. I think prosthetics is a pretty easy sell, as it's a little bit easier to understand. We're restoring something that someone has lost in a very obvious way. You know, a patient has lost their leg and we're replacing it with a prosthesis. The field of orthotics is a little bit tougher to understand because the patient still has all their limbs, but that doesn't mean they haven't lost anything. My specialization is in Ehlers-Danlos syndrome, which is a joint hypermobility syndrome, which usually manifests around adolescence in kids. And these are kids who are normally developing full active, playing sports, running on the playground, everything like that, until they start to hit adolescence, 11, 12 years old, and then suddenly they have chronic pain. Their joints become hypermobile and are very prone to dislocation. They can dislocate their shoulders and hips just by rolling over when they're sleeping. So these patients had this level of activity, had this lifestyle that was suddenly taken away from them. And as an orthotist, it's my hope that I can sort of restore their ability to participate in those activities once again. So allowing for activity-specific or sport-specific orthoses to restore function and prevent injury in these patients would be immensely beneficial to restoring what they've lost. Thank you.
Thank you for your testimony. Thank you, Madam Chair, for this piece of legislation and some really personal testimony and the bravery for being here. Are there any questions of this panel? Seeing none, thank you all so very much. There's, there's a witness, Madeline Huffner, who signed up favorable, but there's also Sarah Peters, who signed up favorable with amendments. I'm gonna ask if both could come up to the table at this time to provide their testimony. We greatly appreciate it. And Madeline, you should proceed as you're ready.
Mr. Vice Chair and members of the committee, thank you for the opportunity to speak today in favor of Senate Bill 406. My name is Madeline Hoffner, and I am a doctor of physical therapy with a specialized focus on treating patients also who have hypermobility and connective tissue disorders such as Ehlers-Danlos syndrome. I treat this population because I have the syndrome myself, so I fully understand all of the intricacies. Maryland, like the rest of the country and world, is in the middle of a public health epidemic due to a lack of physical activity. According to the CDC, inadequate levels of physical activity are associated with $117 billion in annual health care costs. And when compared to their able-bodied peers, individuals with disabilities are 47% less active. Senate Bill 406 aims to address a part of current healthcare inadequacies. Currently, people with Ehlers-Danlos syndrome can access custom orthoses for daily use, but when it comes to orthoses specifically designed for dynamic sport and physical activity, there is no coverage. Unfortunately, they are left with two choices. One, not participate in physical activity, which has multiple negative implications on their social, mental, and physical health. Or two, try to be physically active in orthoses that are not designed for such activities, resulting in injury, hospitalization, or breaking of their orthoses. In either of these situations, the state and commercial insurance endures tens of thousands of increased costs per individual. By passing Senate Bill 406, we can ensure that all Marylanders, regardless of their disability, have access to the necessary equipment to stay active, healthy, and engaged in their communities. Not only will this improve their quality of life, but it will also reduce long-term health care costs by encouraging preventative care through physical activity. Thank you for your time and consideration.
Thank you for your testimony, Sarah.
Chair, members of the committee, Sarah Peters with Hush Blackwell Strategies, here on behalf of my client, the Maryland Podiatric Medical Association. I signed up to testify just in case Dr. Lowy was unable because he was seeing patients. He will be testifying virtually. So I'm going to share two things. Friendly amendments, and then also just a personal story. So first thing, we like to see removed modified device. We're not talking about the orthotics that you can buy in Target and elsewhere. We're talking about custom orthotics that are actually going to serve adequately the patient. And then secondly, the congenital conditions, those conditions at birth, which leads me to my personal story, which is was born with a club foot. And if you don't know what that is, it means my right foot was pointed outwards. And the pain that comes with the surgeries and having a club foot is more than just discomfort. I see most of you all day, 8 a.m. until gosh knows when committee dinners end or what have you. But the reality is I don't have an orthotic in this shoe. I have an orthotic for tennis shoes. And now you ask, well, why don't you just wear your tennis shoes? Well, because I'm a working professional who wants to dress in a suit. That being said, my one pair of orthotics that fit in my sneakers weren't even covered. I have to prove that I have diabetes first in which to have them covered. Well, I don't have diabetes, so unfortunately they weren't covered. So I have one pair that fit in my sneakers that don't actually serve me in my real life. So with that, I urge a favorable report.
Are there any questions of this panel? Thank you all so very much for your testimony. We have virtual witnesses. We'll start with Lisa Marcoon, who's signed up as favorable for Senate Bill 406.
Hello. My name is Lisa Marcoon. I'm an occupational therapist and a certified hand therapist in the state of Maryland. I work at Johns Hopkins Bayview Medical Center in Baltimore, where I serve patients with injuries or deformities of the hand and the upper limb. I'm speaking today on behalf of the Maryland Occupational Therapy Association in support of Senate Bill 406. Custom orthotic fabrication is an important part of what we provide our patients. These devices are used to improve the function of the hand, and I think a few examples would be helpful. A patient who suffers a trauma to the hand with surgical repair is referred to an occupational therapist for fabrication of a custom orthosis. It is custom molded to provide appropriate immobilization and positioning during the stages of healing. It may be safely removed to engage in movement exercises that are designed to minimize joint stiffness and deformity. These devices are the standard of care for many postoperative conditions, and not receiving them places the patient at risk of poor outcome or loss of function. Currently, they are not always covered, resulting in inequities in receiving quality care. Another example would be a patient who suffers a nerve injury, resulting in the inability to oppose the thumb of the dominant hand. A custom orthosis can be designed to reposition the thumb and allow them to dress themselves independently, to prepare meals, to use a screwdriver, or to use the keyboard. As occupational therapists, our goal is to return the people we serve to the highest level of function, to perform activities of daily living more independently and without pain or restriction. We hope you will support this bill and the people of Maryland as we limit disparities created by inequitable access to necessary services. Thank you so much for the opportunity to share this testimony.
Absolutely. Thank you for your testimony. Are there any questions for this panelist? Seeing none, we will go to our last witness on Senate Bill 406, and that's Dr. Lowy, who has signed up favorable with amendment.
Thank you very much. Good afternoon, Madam Chair, Vice Chair, and committee members. My name is Adam Lowy. I'm the president of the Maryland Podiatric Medical Association, representing over 260 podiatrists across the state of Maryland. I'm here today to ask for a favorable outcome in support of Senate Bill 406, So Everybody Can Move Act, with an amendment to add congenital deformities to the list of conditions for coverage. Podiatrists across the state utilize custom molded orthotics and devices to provide significant improvements to the functional capacities of our patients. Patients develop pain, pathology, and progressive deformities from the abnormal mechanics that travel through the lower limbs that impacts their everyday lives. These limitations affect their abilities to perform activities of daily living and perform rigorous working environments, and performing physical activities and exercises to maximize whole body health. With the use of custom-made orthotics, these patients can increase their functional abilities in these various fields, which impact their overall well-being for the good. Individuals feel better about themselves and their lives when they can hold meaningful jobs in the community and improve the lives of the individuals that rely on our patients. These custom orthotics have profound impact ways in this way. Lack of access to them would create more limitations in these categories previously mentioned. The bill will provide our patients with continued access to custom-made orthotics and devices, as well as increase their coverage to provide devices necessary to treat and correct specific functional needs and activities. If clinicians can assist patients in providing devices which will allow them to participate in whole body physical fitness in some way, the potential health benefits would be rewarded among the patient's quality of life and happiness. Exercise and physical fitness have been shown to impact mental health and overall well-being. The MPMA has worked closely with the primary stakeholder as our fields work directly with patients that require these devices. And for that, I ask for a favorable vote of this bill. Thank you very much.
Thank you for your testimony. Are there any additional questions? Seeing none, thank you so very much. This ends the hearing on Senate Bill 406. Next, we will hear Senate Bill 474, sponsored by Chair Beidel. Dana Hoffman and Marie Grant are signed up as sponsor panelists. I ask that you all please come to the table. Thank you, Ms. Grant. Madam Chair, whenever you're ready. Dana's on her way.
Thank you, Mr. Vice Chair, members of the Finance Committee. This is my day today. We've got four bills in a row from me, so I apologize. But thank you for the opportunity to present this bill, Senate Bill 474, Health Insurance Adverse Decisions, Reporting and Examinations. Senate Bill 474 seeks to provide the Maryland Insurance Administration with greater enforcement authority to ensure that health insurance carriers are not improperly issuing denials under Maryland's Appeals and Grievances Law. Last session, we passed a comprehensive bill to tighten timeframes, increase transparency, and broaden prior authorization policies under Maryland's Appeals and Grievances Law. However, these laws only help Marylanders if the carriers comply. Over the last several years, we've seen a significant increase in denials. We've all heard from constituents struggling to receive health care services despite paying high premium costs. Between 2019 and 2023, there have been an increase of 38.6% in adverse decisions reported by carriers. Over 109,000 adverse decisions were reported in 2023. Pharmacy services in particular saw a significant increase, about 71.6%, and account for the majority of adverse decisions. Therefore, Senate Bill 474 provides that if the carriers report more than a 10% increase in the number of denials in the immediately preceding calendar year, or more than 25% in the immediately preceding 3 calendar years for a particular service, the carriers are required to submit a report to the Maryland Insurance Administration detailing any changes in medical, management, and any other reasons for the increase. The insurance commissioner may then use this information to institute a market conduct exam. Again, Maryland has strong laws, but we also need strong oversight to ensure compliance. I respectfully request a favorable report on Senate Bill 474.
Okay. Hi, Mr. Vice Chairman, committee members. Marie Grant on behalf of the Maryland Insurance Administration here in strong support of this legislation, and thank you, Madam Chair, for introducing it. I think as I've taken on this role since October and looked into our data, as Chair Beidel was discussing, there's been a really large increase in adverse decisions that we're seeing in our market. Since 2019 alone, we've seen a 40% overall increase. Since 2015, if we look back that far, we have more than doubled in the number of adverse decisions. And these are decisions based on medical necessity, right? These aren't just simple claim denials. You filled out the wrong thing. It's a question of medical necessity. So I do think it's really important for us as the regulator to understand what's going on when these decisions jump. And I think this bill is an important tool to help us do that. So would urge a favorable report. Thank you.
Thank you very much.
Thank you. Go ahead.
I didn't know. Mr. Vice Chair, members of the committee, for the record, Dana Kaufman here on behalf of MedChi and several other healthcare organizations. We are in strong support of this bill. As you heard, we have spent the last 2 years strengthening our prior authorization and utilization review management laws, the appeals and grievance. That law, or the law that passed last year, was really the first time we took that comprehensive review since the appeals and grievance bill had been implemented back in the 90s. But as this committee knows very well, our law is only as good as it can be enforced. And right now we need enforcement to make sure that the trajectory of these denials is reasonable, and if it's not, to somehow work to bring it down. I will point out too that there's a very lengthy process. If you get in a denial, you can go back to the insurance carrier and ask, becomes a grievance. And if you still get a second denial, you can go to the insurance administration and you can issue a complaint and they will look at it. Now, I will say that those numbers are small because it's a very long process and individuals need health care and they need it when they need it. But for those cases, 70% get overturned in favor of the patient, which means those benefits were due to that patient and they only received them after a lengthy delay. So we think that this bill is definitely needed. We need enforcement. We need to make sure that the strong laws that we have are being enforced. So we urge a favorable vote. Thank you.
Thank you, Dana. Are there any questions of this panel? Hiding this mic there. Senator Lamb.
So I just wanted to thank you, Mr. Vice Chair, just to clarify the statistics there that Ms. Grant had provided. So you said there's been a 40% increase in denials since 2019? Is that?
Yes. Yeah.
What do you attribute that to?
So I'm hoping that this bill will help us to better understand, and we're still looking at the data we have. A lot of the majority of that growth, probably the vast majority, is actually in pharmacy. And so I think as we've talked about recently, last week, pharmacy costs, formulary designs, things like that, I'm guessing, but we as a regulator need to better understand what's going on. But yes, 40% since 2019, over doubling since 2015.
But you've probably also seen a greater vertical integration in the market, right? So more and more payers are actually owning their own PBMs, which is causing some of the issues with probably pharmacy denials.
So I think that may be true with some things. I think it's not true with all of our carriers that we regulate. So our biggest carrier does not own its own PBM.
You're talking about Care First?
Yeah,
Okay.
yeah,
We own 60% of the market.
yeah.
Yeah. Okay. But a lot of other ones have their own PBMs attached to them, right?
Yes, yes, yep.
Right. Okay. I mean, it is a startling statistic. I noticed that there's no opposition to this bill, which I'm surprised that the League of Life and Health Insurers of Maryland is not here, but that number might explain why. Oh, I missed the gentleman in the back. Oh, no testimony from our friend back there.
There he is.
I'm glad to see that. No opposition. Thank you.
Are there any additional questions? Seeing none, thank you so very much. This ends this panel. We have two witnesses signed up to testify. Daniel Shattuck is signed up in favorable, and Michael Patty is signed up as favorable with amendments. I'm going to ask both of them to come to the table at this time. And Daniel, you may get started when you're ready.
Thank you, Mr. Vice Chair, members of the committee. My name is Dan Shattuck. I'm here today on behalf of the Maryland chapter of the American Physical Therapy Association, the Maryland Dermatologic Society, and a number of other healthcare providers. I want to thank the chair for introducing this legislation. I think it's a great follow-up to the bill that passed last year and the hard work that's been undertaken these last few years on this issue about utilization review, and in particular, adverse decisions and denials. Obviously, denied care is delayed care. It impacts a number of things, really, with our practitioners. It impacts the medical decision-making. When we're talking about medical necessity, we value the interaction between the provider and the patient to come up with the best care for that patient, specific to that patient. So when an insurance company comes in with an adverse decision, then it throws that decision-making into flux. There's delays to try and get it overturned. And I think, as Dana suggested, and the data shows, that oftentimes when appeals are made, those decisions are overturned. So if there is a way to empower the MIA to give them the tools to look into the frequency of denials and the decision-making, that's going to be a benefit to patients. It's going to be a benefit to providers. I think it helps close some of the gaps around the bill that passed last year. So with that, I ask for a favorable report.
Great. Thank you, Mr. Chairman. Michael Patty here today on behalf of the Maryland Community Health System, a network of federally qualified health centers across the state, providing primary behavioral and dental care to those underserved communities. This is a great bill. I'm quite familiar with this report that the MIA puts out. We did just want to highlight that, we aren't just seeing adverse decisions in the commercial market. We're also seeing them in the MCO space as well. Obviously, the way the insurance article is written, it's not always consistent between what reports are covered and what parts of the law. So we're just, want the committee to remember that as they're considering this report and expanding this report, that, we still see these issues with MCOs and their adverse decisions as well.
Excellent. Thank you for your testimony. Is there any questions for this panel? Seeing none, thank you so very much. This ends the bill hearing on Senate Bill 474. Next, we'll go to Senate Bill 475, where guess who? We have Chair Beidel, who will be joined at the podium by Dana Kaufman. And Dan, you didn't go too far away. If you want to come up behind them, could move things along a little bit since you're also signed up as favorable. Madam Chair.
Thank you very much, Mr. Vice Chair. Senate Bill 475, thank you for the opportunity to present Senate Bill 475. This is the health insurance utilization review. You may remember a couple years ago, we passed a value-based care arrangement so that providers can do a two-sided incentive agreement and capitated payments. It may be that they are treating someone and realize that they need transportation to the doctors or therapy. They may need a better diet, nutrition. Those are additional value-based services that a doctor can provide. But given the cost of health care, value-based care delivery is seen as a way to increase quality and decrease cost. However, the uptick of these arrangements has been slow. To incentivize providers to consider and enter these arrangements, Senate Bill 475 would prohibit health insurance carriers from imposing a prior authorization, step therapy, or quantity limit requirement on providers for health care services included in a two-sided incentive arrangement. Last year, during the hearings on the prior authorization legislation, we heard that physicians had to hire additional staff to process all the prior authorizations required by insurance companies, and that almost 2 full days were dedicated to completing these requests. Prohibiting these utilization management policies from being part of these arrangements will hopefully incentivize more providers to enter into them, given the cost savings that may be associated with the prohibition. I urge a favorable vote on Senate Bill 475.
Mr. Vice Chair, members of the committee, again, for the record, Dana Kaufman here on behalf of MedChi and other physician groups. If you bring a group of physicians into a room and ask them what their biggest challenges are, they're going to say 2 things. They're going to say low rates, and they're going to say the utilization review management techniques instituted by the insurance carriers. When we passed in 2023 the two-sided risk, to be very clear, what this two-sided risk means is that the physicians are on the hook for the risk, just like the insurance company. So they could be subject to repayments or recoupments back to the insurance companies if they don't meet certain contract metrics. One of the things that we've been thinking about is how do we incentivize, but also really look at what is one of the most timely issues that the physicians' offices are dealing with. And as you can see from legislation that has been introduced this year, there's about a dozen bills that are looking at trying to exempt prior auth and step therapy from either pharmaceuticals or different diagnoses. And the reason that is because it frustrates both patients and physicians, especially the patients. So what we've been thinking about with this bill is if you're going to accept two-sided risk and be responsible for managing that patient, then you should be able to manage it without having to go through those processes. So you will have the autonomy to manage that patient, and you will also be able to then hopefully free up some dollars that you're spending now on that process. So we think it is a good win. Other states have looked at doing things like the gold card, which is if you, get so many percentage of prior auths approved, then next year you don't have to do prior auths. That becomes a lot. So this is really taking that small subset of those who are entering in their voluntary agreements and then taking away this very time-consuming process. So we urge a favorable vote on this. Thank you very much.
Thank you. Dan?
Mr. Vice Chair, members of the committee, Dan Shattuck here again today on behalf of a number of our healthcare clients. Dana really laid things out pretty well. I think when we look at emerging models of care and especially the two-sided risks, it makes sense to put the physicians and the providers in the best possible position to succeed. The whole point of value-based care is to come up with ways to improve efficiency and improve quality care. So the patients that are taking part in this, I think, have an expectation that by being a part of a model or a two-sided risk venture, they're going to get the best and less impeded care. And I think for the physicians and the providers involved in these models, the best way to demonstrate quality is through the medical decision-making, the care plan that's established between the patient and the physician and the provider, and not have to spend the time, the money, the energy to go through the typical utilization reviews or step therapies or what have you. I think that's by design. These models are supposed to take you out of that normal healthcare mix, create a special subset. So it just makes sense to eliminate those administrative burdens in these models. Thank you.
Indeed. Thank you for your testimony. Is there any questions for this panel? Seeing none, thank you all so very much. Next, Senator Lamb, have your wishes. Not too far behind. We have Matthew Celentano, Kimberly Robinson, Jennifer Witten, and Jake Whitaker, all signed up as favorable with amendments.
Deb?
Well, this is a rare
This is a table.
friends.
Would you like to go first?
Sure, absolutely. So, Mr. Chairman, committee members, Jennifer Witten here on behalf of LifeBridge Health. Here in support and conceptually of the bill, I think my colleague Dana Kaufman laid out generally, we are very supportive of looking at ways we can reduce utilization process and pre-authorization, really to ensure we can deliver the right care without delays. However, what's being proposed, we feel like needs a little bit more, I think, details around some of the safeguards that we would want to ensure in place. By taking out the insurers and the pre-authorization, we may be unintentionally shifting more of the risk to the providers. I will share with the committee, LifeBridge Health has been slow to adopt some of these value-based arrangements. We are just really looking at how that shared risk goes. But by removing, I think, the carriers in some of these unique models, we may be unintentionally putting more risk on the providers. We think if we can look at who's attributed to these models, meaning which patient populations, how we look at cost measures, and how we look at process, this could be a very valuable tool for us. I know this committee has talked a lot, and we just heard about some of the denial rates. But for example, we have a number of providers who are prescribing, let's say, Wegovy, for example, very clinically sound therapies, but highly expensive. So if we take out that pre-authorization process and the risk shifts to our physicians, what would that look like if we basically trip the cost control methods and we go outside of that patient population? We think we should allow our clinicians for that discretion, but we would just like a little bit more detail on some of these arrangements. So concept-wise, absolutely in agreement, would just like some more details. So thank you for that consideration, and happy to answer any questions.
Mr. Chair, Matt Celentano here on behalf of the League of Life and Health Insurers, favorable with amendment on Senate Bill 475. As you remember, the General Assembly passed a bill that enabled value-based care for the first time in Maryland in 2022. And it enabled limited and voluntary arrangements in value-based care. And my friend to my left, her company was the proponent of that legislation. It was looked at as a foot in the door to further value-based care on a broader scale at some point in Maryland. When we were having one of those discussions, one of the overarching themes was that if we enable value-based care over the long term, it would promote equity, improve health outcomes, and importantly, it would reward and incentivize doctors to create better outcomes by utilizing services that lead to better health. Right? That's the whole basis of value-based care. It works. It absolutely works. And when physicians have skin in the game, it especially works. That's what we're seeing in the vast majority of this country. Maryland's value-based care program is very limited and still in its infancy. When doctors are rewarded financially, they achieve better outcomes. When they don't, their reimbursements suffer in traditional value-based care arrangements. So carriers, we're completely on board with the concept of this bill, and we're happy to remove some of the utilization management tools if it's a true two-sided risk arrangement. But currently, it's really just on the carrier. There's not a lot of skin in the game from the docs. So what we would like to do is continue this conversation and get to a place where we can build risk into the relationship. We can then remove some of the tools that some of the folks on this committee do not like, and we can get to a more balanced approach to value-based care. So we respectfully add for a favorable with amendment report. We want to work on this. We want to expand the world of value-based care that will lead to better outcomes for patients. I thank you for your time.
Good afternoon, Mr. Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. As Mr. Celentano shared, when this bill passed in 2022, it was a piece of legislation that was spearheaded and brought forward by Care First Blue Cross Blue Shield, worked in partnership with the provider community to get to this very beginning stage of adopting value-based care in the state of Maryland. If you were to look across the country at what value-based care looks like in other states and in other markets, Maryland's bill would truly be described as being in its infancy. It is incredibly restrictive. It does not allow for the flexibility or the breadth of models that are flourishing in other states. And it was done incrementally so that our providers here could get comfort with the arrangements. But what we see is that there's not been a tremendous uptake on the two-sided arrangement version of value-based care. This bill that would remove all utilization management, all prior authorization specifically, from those particular practices is set up in such a way that without that balance on the risk, you simply could find yourselves adding cost into the system. We know that's not the intent we understand exactly what the proponents are looking to do, and it is something we absolutely support. We do think value-based care is what is going to best serve providers, carriers, and patients in our state. And we are happy at the opportunity to continue to have this conversation. I think when Ms. Winton was talking about some of the concerns that even the hospital system was having about what happens when you remove prior auth, it's why you see fiscal notes on bills right now. When you have something that is not subject to prior auth, that is going to be very costly, that cost goes somewhere. And so if we're going to have that intention of trying to get what is felt like to be a barrier by providers out of the system, it does require making sure there's all the intentionality in the world to keep those costs down and be effective in how we're providing that care. I think that we find that providers who are in these arrangements right now are finding themselves very happy, and we are excited to be part of moving this forward in the future.
Indeed. Thank you so much for your testimony. I called Jake Whitaker, but I don't see him at the table, nor do I see him in a room. Last call for Jake Whitaker. Are there any questions for this panel? Seeing none, thank you all so very much.
Thank you.
Indeed. This ends the bill hearing on Senate Bill 475. Next, we will hear Senate Bill 476. Chair Bidle will be our sponsor, accompanied by Rachel Joseph, Angelica Katz. And we have two additional favorable testimony from Patrick Hogan, as well as Lisa Peabody. If we could have everyone come up to the table and join Chair Bidle in testimony, we greatly appreciate it. You may get started when you're ready.
Good afternoon, Mr. Vice Chair, members of the Finance Committee. Again, this is number 4 of 4. Thank you for the opportunity to present Senate Bill 476, Health Insurance Genetic Testing and Cancer Imaging Required Coverage and Prohibited Cost Sharing. This bill increases access to recommended genetic testing for inherited gene mutations and evidence-based screenings by eliminating burdensome patient cost-sharing requirements. Genetic testing can provide important information to breast cancer patients, their families, and their medical providers. The results from genetic testing is often a catalyst for patients to access targeted prevention and treatment strategies. In the U.S., approximately 5 to 10% of breast cancers are related to a known inherited gene mutation. Most patients have heard of BRCA1 and BRCA2, but they are not the only breast cancer-related genes. Now it's more common to be tested for multiple other moderate to high-risk gene mutations in a practice called panel testing or multi-gene testing. This is a health equity issue according to a 2020 American Association for Cancer Research report. 65% of young white women with breast cancer were offered genetic testing, whereas only 36% of young black women with breast cancer were offered the same testing. Additional studies show that minority patients were more likely to utilize genetic testing following a cancer diagnosis and less likely following a family history of cancer, resulting in a missed opportunity for mutation of detection and cancer prevention. This is important because we know that black women have a 40% higher mortality rate for breast cancer than their white counterparts. By eliminating the cost barrier to genetic testing and evidence-based screenings, individuals will have access to critical information regarding their lifetime cancer risk and ensure they have access to medically recommended early detection and cancer surveillance. Therefore, I respectfully request a favorable report on Senate Bill 476.
Thank you. I called 5 people up to the table. It looked like you might not have got there. I'm sorry, can you state your name, ma'am?
Lisa Peabody.
There you
Thank
go.
you. Sorry about
Thank you,
that.
Lisa. No problem.
Guys, we're moving so quickly. It's great.
Thank you, Delegate Hayes and members of the committee. We appreciate the opportunity today to provide testimony in support of SB 476, which relates to coverage of genetic testing for inherited cancer mutations and the recommended screenings based on the results of that testing. My name is Angelica Katz, and I am the Regional Manager for State Policy and Advocacy at Susan G. Komen. For those of you who might not know, Komen is the world's leading nonprofit breast cancer organization representing the millions of people who have been diagnosed with breast cancer. And we're here today to advocate on behalf of the estimated 6,270 people in Maryland who will be diagnosed with breast cancer and the 830 who will die from this disease in 2025 alone. As Senator Beidel has already summarized the bill, I won't go over that piece, but I do want to just reiterate that approximately 5 to 10% of breast cancer is inherited, and the lifetime risk of breast cancer is increased between 20 to 49% for women with a gene mutation, and 50% are higher for women with high-risk gene mutations. Identification of inherited cancer risk can help guide decisions for medical providers in just making sure that patients receive the best treatment that they need. We did have an advocate who unfortunately had metastatic breast cancer, and because she did do the genetic testing, she was able to then modify her medical treatment, and she was able to live 14 months longer than she would have lived already. So we know that genetic testing is important. It's more of a prevention tool. It also is also a cost savings tool as well, because if you know that you have an inherited gene mutation, you're more likely then to, like I said, modify your medical management and try to make sure that you treat that risk. So with that, I know I'm up, and I will pass it over to Rachel. Oh, there it is. Sorry. Thank you.
Senator Beidel and Senator Hayes and members of the Finance Committee, thank you very much for the opportunity to testify. My name is Rachel Joseph, and I'm a resident of Montgomery County, Maryland. I'm a two-time breast cancer survivor. I was first diagnosed when I was pregnant with my second child. Within a 2-week period, I had a C-section, delivered a healthy baby boy, celebrated a bris for my son, underwent a lumpectomy, and started chemotherapy, all at Greater Baltimore Medical Center. Younger women, like myself at the time, diagnosed with breast cancer are more likely to carry an inherited genetic mutation, and my oncologist recommended that I undergo genetic testing. At the time, clinical guidelines recommended only testing for the BRCA1 and BRCA2 genes. Unfortunately, I was negative. However, my cancer did recur, and 8 months later, I had to undergo another round of treatment. Our knowledge of genetic mutations and their role in breast and other cancers has increased exponentially. Now we have access to multi-panel gene testing. And just last week, I, at the recommendation of my provider and after genetic counseling, underwent another round of testing. I think this information will be vital for me, for my son, and for my daughter to understand our risk profile and to undergo preventative screenings that may be clinically necessary and recommended. However, I did learn from my insurance company that the out-of-pocket costs for this could be as much as $800. And that doesn't include the cost of the genetic counseling visit. No woman should have to forego the recommended screenings due to cost consideration. So I urge the committee to support SB 0476.
Thank you, Mr. Vice Chair. Members of the committee, for the record, Patrick Hogan with Cornerstone Government Affairs, representing Susan G. Komen. And special thanks to Chair Beidel for sponsoring this legislation. The chair, Angelica and Rachel, shared all the key points already. I just wanted to simply briefly highlight a recent study that the Maryland Healthcare Commission put out on the impact of this bill. And one key statistic, the report indicated that this change would increase premiums by just 0.00 or 0.06%. So this would have a great benefit for patients with a minuscule or possibly no real impact on premiums. So if you don't have a copy of that report already, we will make sure you get it. With that, I will stop and just say thank you and ask for a favorable report on SB 476.
Hi, my name is Lisa Peabody, and I'm a longtime resident of Maryland, and I'm also the advocacy manager at FORCE, and we represent those patients who have a genetic mutation. that puts them at high risk for not only breast, but different other mutations that put them at high risk for colorectal, prostate, gastric, and a variety of other cancers. Many of our patients are previvors. They haven't had cancer yet, so they are complying with those recommendations, those medically recommended guidelines to start screening early because of their high risk of cancer. And you've heard about the BRCA mutation from my colleagues, but Lynch syndrome, which is a combination of 5 genes, has the highest prevalence. 1 in 300 people can have Lynch syndrome, putting them at an 80% risk of cancer, this group. And so they're in this high-risk group, yet when they go to access their screening, they need to start before the age of 45, which is what the law says. But the medical guidelines suggest that these people start screening as early as 20 and 25 years old. Often the cost of a colonoscopy is outrageous, and it's for young people, and it's applied to their deductible in full, and they forgo those services. And this is the highest risk group, and yet they're not covered by the federal law. So this closes a gap for these previvors. 10% of cancers are genetically part of a genetic mutation. So it's not all people are going to need this screening. It's only this group of people who have this high risk because of a genetic mutation like a BRCA or a Lynch or one of the 40 other cancer-related high-risk mutations. And then in terms of the multi-gene testing, the law says right now, the federal law says that only coverage of BRCA is required. And patients need more than just BRCA, right? Because Lynch is 1 in 300. So we want to make sure that those genes are also included when patients go in for their screening. So thank you so much.
Thank you for your testimony. Are there any questions from this panel? Seeing none, thank you all so very much. We have 2 signed up unfavorable, and I'm sure we could guess who they are. Matthew Calentano and Kimberly Robinson. Please come to the table.
We like catch strays where it isn't even my bill, so. Mr. Chair, members of the Senate Finance Committee, Matt Celentano here, respectfully opposed to Senate Bill 476. While we certainly want beneficiaries to receive all preventive services in a timely manner, we're concerned that the tests in this bill do not provide the medical effectiveness and accuracy that we expect in covered services. Although genetic testing is highly accurate in identifying genetic variations, detecting a variation associated with an increased risk of cancer does not guarantee that the patient will develop the disease. Only about 10% of all cancers may be caused by genetic inheritance. In the MHC's interim study that was referred to before, they wrote that, quote, providers noted that the percentage of individuals that will test positive for a cancer genetic variation are in the minority. And since the individuals who test positive for a genetic variation represent a small percentage of the population, and cancer screenings are generally covered by insurers as a preventive service, they also noted that the accuracy of these tests is about 40 to 50%. That is not the accuracy the carriers are accustomed to sort of covering. We just don't think it's timely. The study also showed that private health insurance already covers genetic counseling and testing with low or no out-of-pocket costs for people with family cancer history. We believe this bill is repetitive and just creates more added cost. This was echoed by multiple physicians on the MHCC that said this approach was not medically necessary. It would only add cost to the system. Multiple commissioners also noted with the explosion of direct-to-consumer testing in this space, of which the tests are even less reliable than the ones that are ordered through the labs, we could be adding additional consumer anxiety. One thing that I wanted to note before I run out of time is that one of the proponents talked about the additional premium at 0.0 or 6%. But what that really translates to is about 53 cents per member per month. We've talked about this a couple times this session. Anytime over it's 5% or 5 cents per member per month, we get anxiety. This is 53 cents per member per month. We have to be unfavorable, unfortunately, on this bill, Senate Bill 476. Thank you.
Good afternoon, Mr. Chair, members of the committee. Kimberly Robinson for Care First Blue Cross Blue Shield. I actually don't even know what to add to what Mr. Celentano said. I think he did a really thorough job of expressing the fact that this is a service that we do currently cover. because I've been very vocal about it over the course of the years, CareFirst covered my own genetic counseling and genetic testing over a decade ago. At that time, it was for BRCA1 and 2. Because it is an important part of helping to identify people when you come with a very significant family history and are seen as having that predisposition to potentially having certain cancers. The cost of this bill is surprisingly significant. As Mr. Celentano said, when we look at the studies done by the Maryland Healthcare Commission, whose job it is to help this body understand the cost implications of some of these mandates that come this way, 5 cents is considered the threshold for things that aren't going to start to drive up premium. In this particular bill, you have the combination of the cost of the testing that's being recommended outside of what is being covered today, but also the shift in cost sharing. Cost sharing is always going to be a challenging subject. The first thing to allow someone to access healthcare in our system is the ability to forge a premium. And we talk about how expensive health insurance is all the time in the state, but over the years, we've seen more and more mandates that are being passed that have no cost sharing except for HSA plans, because you can't change those by federal law. And at the same time, we have a lot of consternation about the uptake of HSA plans, that so many people are in plans that have these high deductibles, but they're choosing them because the premium is lower. And so the more costs we pack under policies that do not have a high deductible, the more we actually drive people to high deductible plans. It's this interesting loop of how the economics of people's choices work. The goals of the bill are laudable. The interest in health equity is certainly something that we're working very hard on, but for these reasons, we urge our unfavorable report.
Thank you so much for your testimony. Are there any questions? Seeing none. We have 2 individuals signed up for virtual testimony as favorable. We'll start with Dale Jafari. Dr. Jafari, you may proceed. You will need to take your get off of mute for us to hear you. Dr. Jafari, can you hear us?
Good afternoon, Chair Bidle.
Dr. Jafari, you may proceed. You will need to take your get off of mute.
Good afternoon, Chair Bidle, Vice Chair.
Do you have the? Jafari, can you hear us? Do you have the?
Yes.
This playing in the background?
Good afternoon, Chair Bidle.
Jafari, you may proceed. You will need to take your get off of mute.
Good afternoon, Chair Bidle, Vice Chair.
I'm sorry. Do you have the? Jafari, can you hear us? Do you have the?
Yes.
This playing in the background?
Good afternoon, Chair Bidle.
Jafari, you may proceed. You will need to take your. This is weird.
Good afternoon, Chair Bidle, Vice Chair.
I'm sorry. We're still hearing the feedback from you from whatever device that you have on and you're listening to. If you could cut that off. This is weird.
Good afternoon, Chair Bidle, Vice Chair.
All right, let's just go for it. From whatever device that you have on and you're listening to, if you could cut that off.
No, cut off your live stream. I don't have any devices on.
Oh, it's good. You're good. You're good. Let's just go.
Okay.
Whatever device that you have and you're listening to, if you could cut that off.
Good afternoon, Chair Bidle, Vice Chair Hayes, and members of the committee. I don't have any devices on. My name.
You're good. You're good. Let's just go.
Okay. My name is Dale Jafari. I'm president of the Nurse Practitioner Association of Maryland, and I'm a nurse practitioner with more than 27 years in practice in women's health, serving your constituents in Kent, Queen Anne, Caroline, Talbot, and Dorchester counties. NPAN stands in support of Senate Bill 476 for the significant improvement in access to specific healthcare modalities related to genetic predisposition for identified cancer-causing mutations. This bill strikes a personal note for me in my women's health practice. Breast cancer rates on the eastern shore of Maryland and Delaware are amongst the highest in the country for reasons that are poorly understood. The care we render to the women we serve is targeted at early identification and, where possible, prevention of the development of breast cancer, ovarian cancer, colon cancer, and other related cancers that may be genetically predisposed. We use standardized risk assessment tools in our practice to stratify our patients into the high risk we already have to the highest risk for those with a genetic mutation. We use a scoring tool called the Tyrer-Cuzick Breast Cancer Risk Assessment Software to calculate multiple personal and family factors that relate to genetic predisposition, resulting in a lifetime percentage of risk for the development of such cancers. A score of 20% or more is considered higher risk and triggers our high-risk breast protocol. This enhanced screening makes it more likely that we will identify a developing breast cancer at the earliest possible interval, where 5-year disease-free breast cancer survival rates may exceed 95%. We follow the evidence-based practices set forth by the National Cancer Compendium in staggering breast imaging with mammogram and breast MRI at 6 months intervals. And we see these patients for a clinical breast exam every 6 months rather than once a year. Those who are identified with a genetic mutation can be offered prophylactic mastectomy or chemoprophylaxis with tamoxifen to reduce the risk for cancer development. In so doing, these high-risk individuals may be spared from developing a life-threatening breast cancer and will continue to actively participate in the lives of their family members, as well as to be productive members of society. I ask for a favorable determination for Senate Bill 476.
Thank you, Dr. Jafari. Seeing no questions, we will go to Marlena Barbera.
Good afternoon. My name is Marlena Barbera, and I'm here today both as a patient and a provider, someone who has seen firsthand the critical importance of genetic testing in cancer prevention. I am a lymphedema therapist, a subspecialty of occupational therapy that focuses on managing swelling, particularly after lymph node dissections performed during oncology surgeries. Additionally, I'm a proud member of the Maryland Occupational Therapy Association, which represents, supports, and advances the practice of occupational therapy in Maryland. I am here in support of Senate Bill 476 because I have lived the reality of what happens when genetic testing is not covered. Due to a very limited family history, I had no way of knowing whether I carried a hereditary cancer mutation following a scan that revealed high-risk cells in my breast. Despite this uncertainty, my Blue Cross Blue Shield insurance would not cover genetic testing, forcing me to pay out of pocket just to obtain the critical information I needed. Because I had this preventative information, I made the difficult decision to undergo a prophylactic mastectomy. I was fortunate that I could afford this test, but many cannot. And without coverage, this kind of testing loses its preventative power. A genetic test is far less expensive than chemotherapy, radiation, surgery, and years of follow-up treatments. Studies show that preventative measures save the healthcare system millions of dollars by reducing the need for late-stage cancer care. Yet too many people are unable to access these tools because insurance won't cover them. On the provider side, as a lymphedema therapist, I've treated countless patients who were unsure if their cancer was hereditary until after diagnosis. Had they known earlier, they might have pursued enhanced screening or preventative measures like me. Instead, they face costly, life-altering treatments. Senate Bill 476 is about ensuring that all Marylanders, regardless of their financial situation, have access to life-saving information. I urge you to support this bill and help create a healthcare system that prioritizes prevention over crisis care. Thank you.
Thank you so much for your testimony. Are there any questions? Seeing none, this ends the hearing on Senate Bill 476. As Madam Chair make our way back to the podium, we'll call Senate Bill 518. Senator Charles, you have 2 virtual witnesses. The first is signed up favorable, and that's Aaron Wright. Senator Charles, you have as much time as you need.
Thought we had Rebecca Stone. There she is. All right. So I have Rebecca Stone, Dr. Rebecca Stone from Johns Hopkins, the director of the Kelly Gynecology Oncology Service Group. And so Aaron Wright, is Aaron a part of our favorable panel? Okay. Yes. Thank you, Aaron. All right. Good afternoon, Chair Bidle, Vice Chair Hayes, and members of the Finance Committee. For the record, I am Senator Nick Charles, and I'm testifying in strong support of Senate Bill 518. however, with necessary amendments, which will mandate ovarian cancer prevention through salpingectomy coverage and eliminates prohibited cost sharing for the preventative service. This legislation is essential to improving health outcomes and addressing significant disparities for women across the state of Maryland. I just want to start by saying that I originally submitted this bill because I truly believe that the state has an obligation and a duty to support significant improvements and access to health care and quality of care for women across our state. As we talked about it yesterday, I was a little misguided and believed that my bill was just a simple bill. And I just want to start and let you know that this bill will require coverage for screenings for ovarian cancer. But what came out of that simple idea was an incredible and enlightening discussion with subject matter experts and remarkable doctors who have educated me considerably on this topic. They have been fighting for education and coverage on this simple, practically zero-risk procedure for years, and I'm honored that they have trusted me to carry this amended version of Senate Bill 518. Fallopian tube cancer, which is often referred to as ovarian cancer, remains as one of the deadliest cancers among women. There are no screenings, no tests, or known ways to detect fallopian tube cancer, which is why we have dramatically amended this bill. The only known and proven way to support care and prevention of ovarian cancer is by removing the fallopian tube through salpingectomy procedures. We have Dr. Rachel Stone here, a genius in this field that can speak to the procedure better than I can. But let me just finish by saying that this bill is more than necessary. Maryland has an opportunity to lead in addressing this critical issue. Enacting Senate Bill 518 will place Maryland at the forefront of this vital health initiative, saving lives, reducing health care costs, and advancing health equity, especially for women, which have been statistically shown to have less access to this important life-saving approach. Senate Bill 518, mandating coverage of salpingectomy procedures for ovarian cancer prevention, is a good bill. If we can cover colonoscopies for men, which are more invasive, more costly, and more routine, we can cover this life-saving procedure for women. I urge the committee to vote favorably on this bill to protect lives, address disparities, and ensure a healthy future for all of Maryland's women. And I'm going to now pass this on to Dr. Rebecca Stone.
Thank you so much. Good afternoon, Madam Chairwoman and members of the Finance Committee. I'm Dr. Rebecca Stone, and I'm a gynecologic oncologist specializing in treating ovarian cancer. I'm here today to testify in support with amendments of Senator Charles' very important bill on ovarian cancer, Senate Bill 518. A woman is diagnosed with ovarian cancer every 40 minutes. It is a devastating and often lethal disease. Despite decades of trying, there is no effective screening test for this cancer. This is related to the shocking discovery that the deadliest and most common form of ovarian cancer actually starts in the nearby fallopian tube, the tube that connects the uterus to the ovary. Because fallopian tubes are thin and small, there is actually no diagnostic imaging that can routinely see them, no CT or PET or MRI. This is one of the biggest blind spots in the history of medicine affecting women, and it has really hindered the development of screening. The good news is that we can prevent ovarian cancer by removing the main source, the fallopian tube. Fallopian tube removal is known as salpingectomy, and there are large studies showing that it is an effective ovarian cancer prevention strategy. Salpingectomy is low risk, cost effective, and does not cause premature menopause. It can be performed as a single standalone procedure instead of tubal ligation or during many other abdominal surgeries when the additional cost is a few $100s compared to the $1 million or more it takes to treat one woman with ovarian cancer, knowing all too well that her life will likely be tragically shortened. Unfortunately, there are billing, health policy, and insurance obstacles that currently prevent equitable access to salpingectomy. The goal of the amended bill is to overcome these obstacles that we can lead the way in decreasing the threat of this horribly lethal disease for all people through public health initiatives dedicated to life-saving opportunities like ovarian cancer prevention with salpingectomy. And this is why I've come to testify today asking the committee to issue a favorable report. Thank you so much.
Thank you. Ms. Wright.
Yes, hello, good afternoon. My name is Dr. Erin Wright, and I'm testifying on behalf of the American College of Nurse Midwives, Maryland affiliate, in favor of Senate Bill 518. I'm a practicing nurse midwife and an assistant professor at the Johns Hopkins School of Nursing. I hold fellowships in the American Academy of Nurses and the American College of Nurse Midwives, and I practice and teach nursing and medical students about women's health. One of those foci includes teaching about and screening for gynecologic cancers. Ovarian cancer is sneaky. Its symptoms are vague and easily attributed to aging, weight, anxiety, and a large variety of other causes. Unfortunately, as Dr. Stone already mentioned, there is not a sufficient screening tool for this cancer, and as such, most women who are diagnosed are revealed to be late stage in the disease. I am a well-educated and experienced midwife of nearly 20 years, and such was the case for me. I was sent for an ultrasound, which revealed a mass of unknown origin, and was then referred for an MRI, which confirmed neoplasm of the fallopian tubes. I had been finished with my childbearing years for quite some time, and certainly did not need my fallopian tubes any longer. During surgery, I was diagnosed as 3C high-grade ovarian cancer by the people that I work with and the people that I train. Mine is an advanced stage cancer. My predicted 5-year survival rate with this cancer is approximately 39%, and I am on year 3. I am acutely aware of the terminal prognosis for me and for many of my colleagues with ovarian cancer, and as such have decided to dedicate what's left of my lifetime to advocating for people with ovarian cancer, the most deadly of the gynecologic cancers. However, oftentimes, bilateral salpingectomy is declined by insurance company, and payment out of pocket is required of them, making the procedure impossible. This lack of coverage for this procedure is quite literally putting lives at risk. I hope you'll join me and the American College of Nurse Midwives, Maryland affiliate, in supporting this important bill.
Thank you for your testimony. Do I have any questions for the senator or either of the witnesses? Seeing no questions, that'll end the hearing on Senate Bill 518. You okay? It's a little bit easier bill than yesterday, I think, Senator.
Thank you, Madam Chair. I'm hoping you passed this one out.
Thank you.
Thank you.
Next, we have Senate Bill 551, Senator Bailey. There he is. And he does not have a panel, so thank you, Senator Bailey.
Good afternoon, Madam Chair, distinguished members of the committee. Senator Jack Bailey, representing St. Mary's and Calvert County. I'm here today to talk to you about Senate Bill 551. That would prohibit an insurer with respect to private passenger motor vehicle insurance from increasing a premium, adding a surcharge, or removing, altering, or refusing to consider a discount based on accidents or losses caused by a collision with a free-roaming wild animal, and for which the insured was not at fault for the loss. Last year, if you all remember, I came before you with legislation based on my personal experience with this issue. Just to remind you, I was involved in a collision with a deer. I was actually sitting stationary in the road, and the deer ran into me. My insurance company determined that I was not at fault for this accident. Glad that they were fortunate and so understanding. However, this incident was later combined with a previous incident from 2020 and caused my increase in premium to go up 26% for a deer running into me. After last session and the work of this committee, the Maryland Insurance Administration conducted a study to examine current insurer practices with regards to increasing premiums based on collisions with wild animals. The study found that no insurance company in Maryland removed a discount specifically for a collision with wildlife. However, it did find that 7 companies applied surcharges due to a claim for a collision with wildlife, a non-at-fault collision. and 15 companies considered the overall number of dollar amount of claims under comprehensive coverage, including collisions with wildlife, to determine the qualification for a safe driver or a loss-free discount. This Senate bill would prohibit these practices to ensure that consumers are protected from the risk of a premium increase resulting from a non-at-fault deer strike. As we are all aware, deer collisions are far too common in Maryland. I don't believe that Marylanders should be required to pay more for their auto insurance because of an accident for which they're not at fault. This legislation was intended to ensure that Marylanders who find themselves in a similar situation in the future are protected from the premium increase that I experienced. I want to thank the chair and this committee for referring this matter to the Maryland Insurance Administration, and I want to thank them for the study and the MIA for their report on this important issue. You all have a copy of that report. And I would just like to refer and talk about a couple things that are in that report, because it talks about some of our adjoining counties, our states, right, that are adjoining to Maryland. And it talks about the state of West Virginia, and it talks about the state of Pennsylvania, which are two bordering states to Maryland. They top the list across the country for animal strikes. Quick reference to Pennsylvania. Pennsylvania Insurance Department states that if you drive in the state of Pennsylvania, you're every person, 1 in 59 that you're going to be run into by a deer. That's a pretty significant number. The Pennsylvania Insurance Department reminds consumers that insurance companies cannot add a surcharge to auto insurance premiums for such crashes. Under Pennsylvania law, a crash involving a deer or other wildlife is considered a non-at-fault incident. Vehicle damage from hitting a deer is handled under an optional coverage called comprehensive coverage. Your insurance premium should not increase because of a deer-related crash. That is the law in our neighboring state in Pennsylvania. Just going to take just a couple more minutes of your time, because I would like to briefly address some of the opposition to this bill. Now, you remember last year we had hundreds of people that opposed the bill. We're down to just a few because we listened to what you all had to say. But first, some of the testimony in the bill file called charging customers for these accidents a legitimate rating factor. That's MAMIC, and stated that rating factors must reflect the level of risk being insured, IA and B. I will emphasize that we are discussing accidents for which the driver was deemed to be not at fault. This was a fault of the deer. So it is hard to see why risk plays into the need for these premiums to increase, as they can happen to even the safest, the most attentive driver. Any one of us is risked at being involved, and believe it or not, 30,000 deer vehicle collisions in this state every year. I will also add that somehow this risk calculation is not a factor for the vast majority of insurance companies in the state that do not engage in this practice. So only a couple engage in this practice. That was what we found out through that report. Second, I would suggest that rather than pass this bill, it was suggested in one of these opposition letters that rather than pass this bill, we could instead pass legislation that is being heard in another committee to try to prevent these crashes through measures such as building fences. That was MAMIC. Preventing these collisions is a worthy goal, but unless we plan to construct fences on every road in the entire state, this will not solve the problem that bill seeks to address. Finally, you will find one letter of opposition from APCIA that seems to imply that this legislation has certain provisions that were in the bill on the topic that I introduced last year, right down to their quoting extensively from last year's fiscal note. I want to make sure that this is clear. This is a different bill, completely different bill. It is an entirely new bill rather than just a reintroduction or revision of last year's bill, in part because of the concerns that you raised and that we, and specifically I, listened to. Those concerns are not raised in this year's fiscal note because the language that resulted for those comments, that portion of that bill was taken out, the two or few claims. So I would just ask that people simply read the bill. I would request a favorable report, and I stand for any questions.
Do I have any questions for the senator? I think you were pretty clear, Senator. Thank you for your testimony.
Thank you very much.
We do have a few unfavorables. Yep. Gina Rotuno, Robert Enton, and Bryson Popham. And then Nancy Egan was going to be here unfavorable, but she's not feeling well today, so that's an unfavorable.
Good afternoon, Madam Chair, members of the committee. Bryson Popham on behalf of MAMIC, as the sponsor mentioned. That's the Maryland Association of Mutual Insurance Companies, appearing in respectful opposition to Senate Bill 551. This really boils down to one thing, and that's losses. Your insurance company exists because you might have a loss. If you have a loss, they will pay for it. And if that happens, it has to go into future rates. Simple as that. So the question is, if you're not going to charge the person who had the loss anything for it, who ends up paying? Everybody else. And everybody else who did not have losses is going to end up paying for it. That's really the basic math of insurance. That's why we have been permitted for many, many years to include not-at-fault losses along with at-fault losses in insurance rates. And with all due respect to Senator Bailey, I spent a lot of time with him after your work session on a similar bill last year. You remember that, Madam Chair? And I completely sympathize with his unique situation that he had. But please don't make any mistake. If you pass this bill, then you're going to be forcing a subsidy by people who haven't had losses to those who do. So we respectfully request an unfavorable report.
So good afternoon, members of the committee. Thank you so much for allowing me to speak today. My name is Gina Rotuno, and I am the Regional Vice President representing the Mid-Atlantic region for the National Association of Mutual Insurance Companies. NAMIC is the largest property and casualty insurance trade association in the United States with more than 1,300 member companies. NAMIC supports regional and local mutual insurance companies as well as some of the largest national insurers. Our member companies write over $383 billion in annual premiums nationally, and our members account for 61% of homeowners, 48% of automobile, and 25% of the business insurance markets. While we understand the intent of SB 551, we do believe it poses significant issues for how the insurance market operates. While drivers may not be at fault in these collisions, there are still factors such as location and driving habits that may increase your risk. To accurately price premiums, insurers must determine to the best degree possible an individual's risk. In order to offer competitive policies, insurers use a number of different factors and models to predict and analyze potential losses and charge accurate prices based on these to the policyholders. Wildlife collisions are a real and oftentimes unpredictable risk that vary by location, season, and other factors. Ultimately, through risk-based pricing, insurers can offer customers competitive rates while remaining financially stable. Without the ability to adjust premiums or surcharges, insurers may struggle to cover rising costs of these claims, potentially jeopardizing the stability of the market. This could lead to fewer choices for consumers and a less competitive market overall. Because this bill would artificially limit insurers' ability to accurately price and assess risks, if enacted, SB 551 would likely not lower the cost of insurance. For these reasons, I request the committee return an unfavorable report. Thank you so much.
Thank you. Madam Chairman, members of the committee, Robert Enton on behalf of the American Property Casualty Insurers Association. We are opposed to the bill. You know, as you've heard us say many, many times, everything that we do, whether we increase a rate, have a policy that increases a rate, whether we have a policy that deals cancel or non-renew, whatever we do, it's all regulated by the Maryland Insurance Administration. And in order for us to do these things, they have to be non-discriminatory. They have to be actuarially sound. Now, where I live, there are deer all over the place. But, you know, part of the factor in this that gets considered, and it's a fact, is people drive differently. You know, some people are more attentive drivers than others. And, you know, the fact that someone may hit a deer, you know, I see deer that run across the road all the time where I live. And I'm constantly on the lookout for them, quite frankly, because I know where they are and where they tend to cross the road. I just think that what this will do is limit our ability to accurately deal with losses. You know, the fact that I think 7% of the companies use this, if this is an issue for you, you got 93% of the companies out there that don't do this. So, I mean, if it's an issue, then, you know, change your insurance carrier. You know, shop. I shop every year when my policy comes up for renewal. I go to my agent and I tell my agent, I want you to check in, you know, with 5 other companies, and based on, you know, my coverage and everything else and the value of my property and my driving record, tell me what kind of, you know, other rates I can get with the same coverage, and that's what they do. We just think that this is a step in the wrong direction and would ask for an unfavorable report. Thank you.
Thank you. Mr. Enton, I hope you realize your company will have no loyalty to you as you change every year. Isn't that so, Senator Kramer?
The new company likes me, though.
Thank you, Madam Chair. Bryson, question. You stated that if there's a loss, it's a loss regardless of whether it was at fault or otherwise. Somebody's got to pay for the loss. What happens where there's someone like me who, in 50 years, has been paying incredible premiums year in and year out for my insurance, and I don't want to jinx it right now, but I haven't made a claim? Isn't that what I am paying for, so that when there is a loss, and I'm not at fault, although I do question, I mean, you know, look, you pay the premium, that's the whole point, but when it's a loss and you're not at fault, why should the owner of the vehicle who's struck by a deer risk having their premium go up?
2 points, Senator Kramer. First of all, you're absolutely right. You and I have been driving a long time. We don't have accidents, and guess what? We're like the vast majority of people who are insured out there. Most people don't have accidents of any kind.
Understood.
We're not talking about a loss here. The loss is going to get paid. We're only talking about the actuarially approved factor that goes into adjusting the rate, increasing the rate. Let's be honest about it.
Well, and that's what, but the point is, you said, you know, look, it's going to be paid out. Somebody's going to, so that's why your premium's going to go up. But I think the point here is, why does that premium need to go up? Should that not be the value that the customer pays in to the insurance companies year in and year out with their premium? And when they do have to make a claim and it's not their fault, why then should their premium be increased, particularly in an event like this, wild animal?
Here's an example. I can't speak to your insurer, I can speak to mine and many others. People like you and me who drive for a long period of time and don't have accidents, we typically receive what's called a loss-free discount because we don't have losses. Our insurer says, you're cheaper to insure, you don't have accidents, we're going to give you a break.
That may or may not be the case. I don't recall ever getting a break, but.
But this bill would prohibit that.
Why would it prohibit it?
This bill would prohibit taking away a loss-free discount for a deer strike. And it's a loss, let's be honest. It's a loss. It may not be an at-fault loss, and certainly Senator Bailey's example is the only one I've heard in my extensive career where the deer actually collided with the vehicle. He's right. He was not at fault. Nevertheless, he had a loss. And people do have losses that aren't their fault. And insurance is intended to pay for those losses, the losses. And in return for that, they have to pay the premium.
In return for the premium that
Yes.
has been paid.
That's right.
That's my point.
That's right.
Is you're saying, okay, now we've paid out a loss, therefore you're going to pay more. As opposed to, I've been paying my premium all these years, the insurance company has benefited from that premium being paid, and now somehow there's a claim due to no fault of the customer, and yep, sorry about that. Now your premium's going up just by virtue of your making a claim.
Right.
So I'm a little bit at a loss as to the sentiment here, but Mr. Enton.
Yes, sir.
I know you were reading, trying to hopefully, like maybe Ben will forget I'm sitting here.
I was hoping you'd just pick on Mr. Popham, not me, but
you know better than that. Your notion that somebody is a more attentive driver somehow is going to do a better job. I suspect, particularly in the case of this bill sponsor, and I know him very well, I'm guessing he probably has his head on a swivel constantly, particularly because of the career that he had. So I'm guessing you don't get more attentive than the bill sponsor, and yet a deer comes running out, perhaps again, as I mentioned last year, because it recognized the good sponsor from having been up in a deer stand earlier in that week, but goes running into the side of his vehicle. And, I don't think that is something that you can chalk up to some drivers are more attentive than others, and therefore it's on the driver. Sorry about that. The deer ran into you. Perhaps if you'd been more attentive, you wouldn't have to be paying for that. Is that the logic, as I understand what you were saying? You spent quite a bit of time talking about attentiveness in your neighborhood and the deer that are running all over.
Well, look, I think this. I think that when you look at, quote, not at fault losses in general, I think that, if you have, 3 not at fault losses in a 3-year period or a 2-year period, that says, I think that,
You've got a cloud over you, so
right.
what?
It's different than you, Senator Kramer, that have no losses at all, and that's a factor that's based on actuarial studies would say should be considered. I understand that from the senator, and I certainly respect him, that if he was just stationary, wasn't moving, and the deer ran into his car. That's to me an odd set of circumstances, and it's something that the carriers, probably don't deal with.
So how does Pennsylvania
let me say this.
pull this off?
Let me say this.
If the state of Pennsylvania prohibits this practice, How are they making it work?
Can I respond?
Go ahead, Bryson.
I believe, I made a mental note when the senator was testifying to check the Pennsylvania law. I think what he said was you may not surcharge somebody for striking a deer. It did not say removing a discount. Now, this bill says you can't remove a discount. That's different. And that's a big difference. That's a huge difference. So we need to look at the Pennsylvania law to see exactly what it says.
Oh, the other thing, Senator Kramer, is I'm glad you mentioned Pennsylvania law, because I'll remind you that when I come in and say that the law in Pennsylvania is much different than what's in one of the bills that's pending before the committee. You know, I don't know what goes on in Pennsylvania. I don't know what the factors were. I've never seen the law. I doubt that you've seen the law. But, you know, I think that we have a very proactive insurance administration. They make sure that these rates are reasonable, that they're based on actuarial
Understood.
studies. And
We're getting off topic from my question. Real fast, but on that, your opening statement was that we are regulated by the Maryland Insurance Administration.
Correct.
And also the Maryland General Assembly. Wouldn't that be correct, Mr. Enton?
Well, I think on the insurance side, I don't know that anybody that's sitting here is an expert in actuarial studies and how insurance rates are made. So that's why you have a statute that puts this in the hands of the Insurance Administration to deal with.
And the Maryland General Assembly has every opportunity to weigh in on that as well. Isn't that so?
Yes, sir.
Thank you, Mr. Enton. Thank you, Madam Chair.
Thank you, Senator. Senator Reedy?
Thank you. I'm not going to have quite as much of an in-depth questioning, but I've learned a lot listening to this exchange. So just kind of bottom line, is there something we could do to help with this situation? Because I understand you don't want to penalize people who haven't ever had an accident unfairly. I also understand that you can't have it, and that's not what the bill doesn't necessarily do this, but you can't have it open-ended where you never get penalized if you're hit 5 deer in the span of 6 months. Maybe you need to take a different way to work. So, I mean, there's some of that might indicate an element of recklessness or negligence, but it doesn't seem right that you could have an accident with a deer that hits you, where, especially if you could show that it wasn't any sort of negligence or any sort of poor driving. It doesn't seem right that you get dinged on that. Now, I know there are some insurance companies that do accident forgiveness and things like that. Do those plans cover this kind of situation in your experience?
You'd have to check with each individual carrier, Senator.
Well, why wouldn't every carrier be like, you get one free bite of the deer?
Many of them do have loss-free discounts, but I think each has their own conditions for it.
But I would just wonder, shouldn't we make sure every Marylander is availed of that?
I checked with my insurer. I enjoy the benefit of a loss-free discount myself.
That's a nice humble brag there. Very good. Yeah. Okay. Thank you, Madam Chair.
Thank you. Senator Mouse?
Thank you, Madam Chair. And, this is a big deal for our district. We've got a lot of these issues. But so I understand the bill basically says that the insurer is prohibited from increasing a policy rate for a non-fault damage from wildlife. Am I right about what the bill does?
The language is a little more extensive, but that's essentially correct, Senator.
Well, how would you describe it?
Well, for one thing, it covers the removal of the discount. That's a big deal for a lot of people.
It does what?
It covers, let me see if I can. It also prohibits, you can't increase a premium, add a surcharge, or remove, alter, or refuse to consider a discount based on accidents or losses like this. So, in my opinion, that's as important, perhaps even more important, than surcharges are. Because so many of us are in a position, if we are with an insurer that offers a loss-free discount, we want to preserve that. And essentially what the bill does is say, if you have a deer strike, you're not going to have your own premium affected. but that's going to go into the loss pool for everybody else. It's just the way it goes.
Yeah, when you have an at-fault damage, then your policy goes up, right?
Yes.
Right.
Yes,
So
it
it's
does.
interesting because you were talking about you'd only heard of this one case, right? This one case
I've never heard of anything other than the experience Senator Bailey had.
where an animal actually
Ran
ran
into
up
him.
to a
Yep.
sitting car. But what's the difference between a sitting car and a moving car that has no chance to move?
Well,
I mean, that's no fault.
Let me say
also.
this, I've thought a lot about this, in anticipation of today's hearing. Once again, to a certain extent, then, just because it involves a deer, does that mean that you're not at fault at all? If you're speeding 70 miles an hour in a 30-mile-an-hour zone on a country road and a deer darts in front of you, that's a lot different than if you're going 30 miles an hour on a country road and a deer darts in front of you, okay? There are no witnesses to determine who was at fault in these cases, none. The only thing we know is there was a loss. And this is just one factor that gets considered. You got to keep that in mind. We have bills, and we focus on this factor or that factor or that factor. But this is one of dozens of factors that a carrier takes into consideration when determining what your rate should be.
Are there any other types of losses that the insurers are prohibited from including in policy increases and things like that, or is this a novel concept?
All of the losses go into the general rate. I mean, all of the losses across the body of policyholders. So that's, you want to be with an insurer that is profitable. So, because that keeps your rate down.
Right.
And this is just about shifting the burden from one person. Senator, you asked a minute ago about at-fault losses and not at-fault losses. What you didn't ask is a question I'm going to answer. Do you get charged as much for a not at fault loss as an at fault loss?
I meant to ask that.
And I happen to have the answer for that because I checked with one of my insurer clients. And the answer is no, you don't. You pay less for a not at fault loss as a surcharge than you do for an at fault loss. So there is an element of fairness in that, at least. You're still going to have to pay something, just not as much as an accident for which you're at fault.
But how many insurers do not include that consider that don't increase rates for? Do you know how many insurers in Maryland don't?
I'm sorry.
I thought in the fiscal note in the study, it talked about it, and it was, I forget, it was like 94% don't and 6% do.
Mr. Hunton, I believe 7 companies charge for an animal strike. I don't know how many companies are in Maryland, so I can't talk percentages, but 7 companies charge, and all the others do not.
If this is a concern and you live in an area where there's deer running in front of the cars all the time, something you ought to talk to your agent about and find a carrier that, has, in your agent's opinion, in your opinion, is more, doesn't consider that. The other thing is, and Mr. Popham said it, and just make sure, and we've said it here before, every time we pass a law that singles out this type of claim or that type of claim, and you can't increase the rate, you can't deny coverage. The cost of paying out claims is the cost of paying out claims, period. And if we can't underwrite based on your claim history, whether it's this claim or some other claim, that cost is still going to get factored into everybody else's rates. You're going to pay for it, and so is everybody else going to pay for it in some fashion, because the insurance companies have to make sure that they can pay the losses out that people make. This isn't going to reduce the number of deer incidents, but it is going to then kind of spread it out over everybody, which means to a certain extent, I don't know how much, everybody's rates will go up if you can't single out this particular type of loss. That's how it works.
I could go on, but I very much appreciate the study, and it is a real issue.
Happy to come discuss it with you further.
Yeah, I think I had And in about 8 years, I think I had 6 deer strikes.
You have
One I could
personally?
probably call myself. I even had one that was wound up totaling the vehicle, where a deer literally and jumped through the. Senator Kramer isn't here, but I'll spare you I'll spare the details, but totaled the vehicle. But and that happens to a lot of people, and it's a real problem. I think the study said there was over 30,000 deer in 1 year. And that's a huge number.
Look, you got to be, I mean, look, I see them all the time where I live, believe me. You got to be on the outlook for them.
Thank you.
My turn. Thank you all for your testimony. I remember from the original report that it was 7 companies. The letter from Commissioner Grant says 5% of the companies apply a surcharge under comprehensive. So if I can ask Gina from AMIC, do your rates increase or you lose your discount if a stone pops up and breaks your windshield?
I'm not sure, honestly, Madam Chair.
Do you know if your rates go up if hail just comes down out of the sky and damages your car?
I'm not sure.
Can you check these for me?
Absolutely.
I want to know for all the other comprehensive coverages, fire, lightning, wind, hail, flood, broken windshield, do they remove the discount or increase your rates for any of the other comprehensive coverages with these 5% of the companies?
Absolutely, I will get that information to you.
I appreciate it. I just, I think for Senator Bailey, it was even more difficult because he was sitting still in traffic. He absolutely was not at fault. But you're not at fault when hail hits your car. You're not at fault when a flood takes your vehicle away. You're not at fault when you're struck by lightning. And I don't think you're at fault when a deer runs out. I don't know how many miles an hour a deer runs, but you really don't have control of that when it runs right into your car. And so I really would like the rest of that information. Both increase the rates and remove claims free discount. That's the 2 questions. So thank you, Gina, for being here. But only 5% of the company. So, Senator, if this doesn't work out for you, you might want to shop insurance. There's 95% of the companies out there that can help you. Thank you very much for your testimony, gentlemen.
Thank you, Madam Chair.
Thank you.
Thank you.
Bill 551. We're now going to go to Senate Bill 547, Commission to Study Health Insurance Pooling Establishment. We have Senator James. I'm sorry you had to wait so long, Senator James.
Well, I learned a lot myself. So, because I live in an area where development has pushed deer into my farm and the 4 farms around me, so we are constantly dodging.
Well, I'm glad it was helpful to you.
Very. By the way, I might be hallucinating because I've had the flu. I'm not contagious, but your committee seems much brighter and cheerier than mine.
We are a cheery group.
So I just thought that was just a refreshing thing. I was like, let me come into the light of the finance.
You also have Delegate Dan Morheim on virtually as part of your committees.
I do. And I will be very brief and then just see if you have questions because I think this is a pretty straightforward and easy bill. So this would allow for at least the opening up on studying the pooling of health care benefits. I'm going to backtrack because this is really like a Forrest Gump moment. But when I was a baby in college, I worked for Senator Jack Lapidus. And my father was the state treasurer, and he had a very bright idea, which was to create the local government investment pools. This is 81. And it was really different. It languished a little bit, but once the treasurer worked with the senator, it took off, and I'm going to show you. Here's the 2024 report from Treasurer Davis. This has been a wildly successful sort of collaboration between state and local governments, taking the burden off of local governments that don't want to administer their own retirement and pension systems and can garner all the benefits and leverage of a much larger system, which is the state. That is the exact same principle behind the effort of this bill. Now, this bill does not designate an individual like the state treasurer or comptroller to take the lead. And maybe that's why in 2018, when this bill passed in a slightly different version under a different administration, it might have languished a little bit. But I do think the composition you're going to see in this bill was a little more carefully thought out, a little more broad-based. We acknowledge the treasurer would like to not be on this board. So be it. That is fine. I think my good witness here is going to offer an amendment about having an interim report. But just the idea is we are facing a fiscal issues, as we always seem to be cyclically. There is no reason we should not always be entertaining ideas of collaboration and efficiency. This doesn't mandate anything. It's just let's study it. Let's see if there's some local governments that are struggling and could come into a state system, bring down their own costs. And I will tell you, there is an Exhibit A, very quickly, which looks something like this, I hope, which is, I think this is the Office of Legislative Research report from Connecticut when they were entertaining this bill and in fact passed it. And they looked broadly around the country. Couldn't get a lot of feedback, but I'll give you one example. California's done this. And in California, this is in 2008, my friends. In 2008, California reported there was a $40 million annual premium saving overall to the system. Far more people were able to get insurance coverage, and it brought the full weight of the state's buying power. So that is the genesis and idea behind this. I will stop and ask for a favorable report, but obviously wait for my witnesses to speak, and thank you all for your kind attention.
Thank you, Senator. Delegate Moorheim?
Thank you. Make sure you can hear me, Senator Beidel, Madam Chair.
We
Good.
can hear you. Thank you.
Thank you. Good to be with you all. So this is based on originally House Bill 1400 of 2018. And if you were in the legislature in 2018, you voted for it because it passed the House and Senate unanimously. And so this is, thank you, Senator James, and also Senator Chris West has been helpful to try to get this launched to the point of implementation. And what it does, it's enabling local governments and school systems who often buy health insurance separately to piggyback onto the state program. You know, I got health insurance through the state, and I now, as a legislative retiree, it continues. It was great coverage. But when I was in, before being elected, coverage was not as good. And, it's not, if you work for a big company, the state, Northrop Grumman, McCormick, something, you get coverage. But if you work for an average business, you're struggling. So this allows pooling. And the whole concept of insurance, as you know, is the bigger the pool, the greater the risk is spread. But also in this case, you can get better coverage. So it's efficiency. You don't have to wait for a fiscal crisis to do this. We ought to be doing this and should have been doing this all along. And what it boils down to is an exercise in arithmetic. You just add up the numbers and see what the rates would be if you piggyback into the state system, your local government. And money flows from one to the other. Taxpayers pay to state and local government. State gives money back to the locals and to the schools, wherever the savings accrue. And you can play with some numbers, but I'll just do an easy piggyback. Let's say there are about 100,000 non-state employees who would be covered, give or take. And if, let's say, they pay $10,000 a year for health insurance, some are single people, some are big family, and you saved $1,000 a year, that would be $100 million savings. You'd be saving money, which can go to other things, and providing a better network and likely better coverage. Now, this won't apply in all sections of the state, I understand that, but it's really time to move forward. So what this bill does, things have changed since 2018. And it will allow this commission to really look at this and say, let's pool and see if this makes sense. But generally speaking, efficiencies make sense. So I hope you will support the bill and dig into this issue and see if we can work together to save money and provide better health insurance for all government employees in Maryland at whatever level they are. Thank you, and it's good to see you all.
Thank you very much. Do I have any questions for this? Senator Reedy.
Thank you, Madam Chair. Senator James, thank you for this introduction of the bill. Delegate Moorheim and you and I spoke about this issue, I think, a couple months ago before session started. So if this is already allowed, right, because of the bill we passed, but nobody's doing it or very few people are doing it, and if there was this kind of pooling, what's the objection to this? Is just people don't know about it, government entities don't know about it? Because you may have noticed we're looking for some money around here, or some savings. So I don't know if you could just comment on what's the bottleneck here?
Well, Senator Reedy, thank you for the question. I struggle with that, and I included some comments in my written testimony, which I hope you'll take a look at. But it's several different things, which I'll try and be polite about. But one is just stagnation. People are comfortable doing things the way they do, and it's hard to break out. Yes, it would require work and a great deal of attention to details. And you'd have to work through that. And a lot of the people that actually buy the health insurance for the counties or the school systems are already sort of overwhelmed with other tasks. And there's a certain degree, and I don't, rather share with you offline, certain vested interests. There's always somebody vested interest in the status quo. But, we've changed things before, and you can't, make the omelet without breaking some eggs.
Not to interrupt you, but just is this something where it might be a good fit for some counties, but maybe not others? Or in your view, is it something that could be kind of ubiquitous?
I think definitely we work better for the bigger metropolitan counties, which would include York County, Carroll County. I would include in that. But it's really what I would really like to, there's a commission to study it. I'd actually, for up to me, I'd push a little harder and say every county and school system ought to do the basic arithmetic and transparent in an open way, including all the stakeholders, the employees, the unions, taxpayers, their county councils, and just run the numbers and then be like 2 columns. Here's what we're getting, and here's the coverage, and here how much it costs, and here's if we joined into the state plan. Now, the bigger the pool, also the more people that get into the state plan, that would spread the risk greater across state employees and probably reduce some costs there too. But it really takes somebody to jumpstart it, and I hope that's what this commission would do. And we should explore then, the commission could really ask people, what is your reticence? What's the holdup to just doing the analysis? If it makes sense, proceed. If it doesn't, it doesn't. But I think common sense would tell you that a bigger pool, and the whole states do this now. And I think when I put in the bill in 2018, it was like 10 states. Over 20 states do this now, but you can check with NCSL, because guess what? It may even be more helpful for the smaller jurisdictions because they don't have the buying power.
Because of the scale. All right. Thank you, Madam Chair.
Senator, can I also just say there's that report I gave should be Exhibit A, if it's not, from Connecticut, which looks at 11 states that are really doing this and 21 states that are kind of doing what Maryland is. And if I could just add to what the former delegate said, I look at the prior bill, it wasn't quite what we're doing here. It said it would open up to school boards and some satellite organizations. This is broader. And it does require some cheerleading. It does require some advocacy. It does require some movement. And when you have a change in administration, there's no fault or finger pointing, but it can get dropped if there hasn't been enough traction in the system. But if you would look at this report, you would see that some of the impediments are even larger jurisdictions sometimes are very satisfied. Some smaller jurisdictions, the study found, retiree health benefits, which the state has, is not something locals do. So what I sense from the report, and I should have attached the report that came out of the 2018. If I didn't, I will forward it to you. It is a lackluster report. It's very superficial. And I think it's more complicated. And I think it requires some diligence and continued looking at, and it may be that it does not take fire off in the state of Maryland, but I think it behooves us, I think, to really analyze it very, very in-depth and make sure we understand and the locals understand, and then pass on whether we should ever entertain this or not. But I think we just missed that opportunity ever so much, and it's worth probably re-engaging now. But thank you for letting me add my 2 cents.
We have a question from Senator Lamb.
Yeah, thank you, Madam Chair. I don't know if either of you, and good to see you again, Delegate Morheim. I'm not sure if either of you were participating or had participated in the follow-up to House Bill 1400, but if you can kind of convey to us what happened there in maybe 30 seconds.
Well, that's why I just said to you, Senator Lamb, that if I didn't already do it, I'm going to send you the report that came out of it. The report was due a couple of years later. And you can sort of tell, I've just had it in front of me and I apologize. It's around, all right. Here is the report, and it is just about, oh, it's not very many pages. It looks to me like it was sort of a superficial effort done under the prior administration. No criticism, just saying that I think it's a complicated issue with large jurisdictions, perhaps liking how they're doing things. Smaller jurisdictions may be struggling with how broad their pool is, whether they provide health care for retirees. And there doesn't seem to be anybody driving the analysis here and really digging under the hood of each jurisdiction and each potential participant to decide whether or not what the impediments are, what the benefits are. So now we have a new administration, and it would be, my opinion was, it was very unfair to go to the new administration and say, hey, look at an old bill and a 4-year-old report. Restart this without having the new administration have the opportunity to support some members of this body and the House to support, add some members, and take a little bit more detailed look at it. But I will provide you with this, and I think you too will come away with this isn't quite the kind of report that we had hoped to get out of the prior legislation, and unfortunately this is the mechanism with which to try to reinstart it. Thank you.
May I speak to that? Madam Chair, may I speak to that to answer Senator Lamb's question?
Briefly, please.
There was a side issue in the original bill that would allow nonprofits potentially in the state to piggyback onto the state plan, because two actually do in statute, crime victims and Maryland legal aid. A lot of that report, the study was that, and that was determined for a variety of reasons not to be viable. But the bulk of the report, which is the major jurisdiction or all states pooling, and even the larger jurisdictions would save money. If you would go through that whole report and go to the very last sentence, conclusion, it says conclusion, if everybody did this, money would be saved. And the entire process of that work group was kind of its own thing. They did not include me as the lead sponsor of the bill. They chose not to do that for whatever reason. But even so, their conclusion at the very end was, this will save money. And the likelihood it would save money and give people better coverage, all our state employees and government and school employees. So that's the bottom line. And as Senator James said, hopefully this commission can focus and jumpstart the process. Thank you for letting me add a comment.
Thank you.
I don't see any other questions, so that'll end the hearing on
Thank
this
you all very
bill.
much.
Thank you very much. And thanks for your patience.
Thank you.
Senate Bill, next we'll have Senate Bill 437, Health Maintenance Organizations Payments to Non-Participating Providers, and Senator Lamb. Would you like to bring up Daniel Shattuck? Reginald Brown will be virtual, and that'll be your panel. This is a prior introduction, so we have 2 proponents and 2 opponents.
Great. So good afternoon, Chair Bidle, members of the Senate Finance Committee. I'm here to be able to introduce and testify in support of Senate Bill 437. For the record, Clarence Lamb, Senator District 12. And as was mentioned, this was a bill that had been introduced last year as well. So there may be some awareness and hopefully some recollection from the committee about this issue also. This bill, Senate Bill 437, aligns the law for healthcare provider reimbursements in the HMO market, the Health Maintenance Organization market, with the law for the PPO market, PPO being the Preferred Provider Organization market, by ensuring there's a minimum floor on reimbursement rates. Out-of-network physicians in the PPO market are paid based on a benchmark date adjusted for inflation. This makes sure that out-of-network physicians are paid at a fair rate by insurers. However, the current HMO law does not use the same method to calculate out-of-network physician reimbursements. The current HMO law outlines that out-of-network healthcare providers, apart from trauma physicians, surgeons who are treated differently, may be paid at 125% of the average reimbursement that the HMO paid for the same service in the same region to a similarly licensed provider as of January 1st of the prior calendar year, benchmarking to that. Benchmarking payments to the prior year means that healthcare provider payments may not keep pace with inflation, which is increasing these days. And additionally, tying the rate to the prior year allows carriers to manipulate their network, we believe, in an attempt to drive down the average rate. This bill would add a benchmark date certain of January 31st, 2019, inflated by the change in the Medicare Economic Index from 2019 to the current year. This aligns with the method used to calculate physician payments in the PPO law that exists and is the same date established in the Federal No Surprises Act. By passing this bill, we are not changing the 125% rate in reimbursement formula, and we are not changing the existing protections in place on balance billing for patients. We would be creating consistency by aligning the HMO law with existing PPO law in how out-of-network healthcare provider reimbursements are calculated. We have repeatedly heard about increasing emergency department wait times, as this committee is well aware of. There are a lot of factors that play into this issue. But one factor is a significant lack of staffing, which can be impacted by reimbursement rates not keeping up with the costs of healthcare. You're likely going to hear from carriers that this bill is related to a negotiation between a specific set of emergency department physicians and Kaiser Permanente, and that we should leave this to the contract negotiation process. First, Kaiser is not the only HMO in the state, as there are others, and we have heard from other emergency medicine physicians about similar problems with other companies besides Kaiser. Additionally, the bill, like the current PPO law, applies anytime an HMO member has to use an out-of-network provider. For example, in our rural communities, HMO members may have to use out-of-network mental health providers, and this bill would help ensure that those providers are fairly paid. Finally, this bill is not saying that Kaiser and providers can't negotiate over reimbursement rates. It is only saying, rather, that there should be some floor to these negotiations to work from, just as with the PPO market. And with that, happy to turn over to other members of the panel and take questions at the end. Thank you.
Thank you, Senator. Dan?
Madam Chair, Mr. Vice Chair, members of the committee, my name is Dan Shattuck here from Brocado and Shattuck. On behalf of a number of our clients, including the Maryland Society of Anesthesiologists, Maryland Dermatologic Society, and then the Maryland Psychological Association, the Maryland chapter of the American Physical Therapy Association, the Maryland Academy of Nutrition and Dietetics, there would be more witnesses here, but because of the limitation, this being a reintroduction of a bill, Dana Kaufman was going to be here for MedChi, so we have the House of Medicine in support as well. So I just want to briefly restate some of what Senator Lamb said. Why are we here? So historically, Maryland was actually one of the first states to create a balanced billing prohibition in the HMO market. Because of that, there needed to be a mechanism to reimburse out-of-network physicians. Going back to 1991, between 1991 and the year 2009, this statutory formula was revised in legislation at least 5 times. We have not had an update to this formula since 2009. Why are we here today? You've heard it multiple times, there's a declining in-network contractual rates. It's driving many providers either out of network or forcing difficult negotiations with the carriers. What the current HMO formula does is it allows out-of-network providers to get paid for seeing out-of-network patients. What's changed really is the No Surprises Act. When that came into effect, I think in 2019, when it actually was implemented in 2020 or 2021, that's providing, in addition to protection from balanced billing, it's opening, I think, the carrier's eyes to try and renegotiate contracts, because the premise of the arbitration and the qualifying payment amount is the median contractual rate. What this bill will do is fix the formula as it stands now, so you can't go back year after year and reduce the rate. It's going to give a date certain with that inflation factor and hopefully level the playing field, give the provider some leverage in negotiations. Thank you.
Thank you. Dr. Brown?
Good afternoon, Chair Bidel and committee. For the record, my name is Dr. Reginald Brown. I'm a board-certified emergency physician. I apologize for not being in person, but I'm working clinically later this afternoon. I'm grateful for the opportunity to represent the Maryland chapter of the American College of Emergency Physicians. We lend our strongest support to Senate Bill 437. This bill is modeled after its predecessor in the PPO market. We are aligned with our insurance partners in stating that in-network coverage is optimal for our patients. The PPO legislation has a proven record of bringing us together. And if one thing is clear from the Maryland Healthcare Commission studies, it is that the current HMO market is not fostering in-network partnerships. In 2024, in their written opposition, Kaiser Permanente asserted they are selective about which health providers it contracts with in order to provide the highest quality, affordable health coverage for its members. Last week, I posed this question. Maybe we can get the answer today. Which emergency groups or providers in Maryland are they contracted with? What is their example of the highest quality, affordable emergency care in Maryland? Is it all emergency providers, some of us, or none of us? In 2021, prior to the NSA, USACS was in network with 95% of insurance paid. That percentage dropped to 90% in 2024. The delta, Kaiser unilaterally pulled out of network contract. Emergency providers and our nursing colleagues care for all patients that come through our doors. We are the safety net for pandemics, mass casualties, and the current flu surge. We care for those inadequately insured, whether or not their insurance company is negotiating fairly. We are not selective. We provide high quality care to all. The opposition will claim that this is an emergency medicine bill or claim that it is about a provider dispute with U.S. Acute Care Solutions. They also cite the MHCC study. Well, why is the data from Kaiser, representing, according to their testimony, ensuring nearly 500,000 Marylanders not included? I'll close. This entire committee is aware of the ED wait times crisis. Your constituents are demanding change. Senate Bill 437 is critical to fair reimbursement for our providers. I implore you to consider a favorable report in support of our patients, reduce wait times, and high quality care in emergency medicine.
Thank you, Dr. Brown. Before Senator Guile, I have a question. We have a letter from MedChi that says that we have a sponsor amendment to hold harmless some specialties that are concerned the rates could decrease. Do you know about that amendment, Senator Lamb?
Yeah, I think we have requested amendment. We're still waiting on
Okay.
it. And so
Just
we'll
wanted
share
to
it
make
with the
sure you
committee
were going
once
to
it's
address
ready.
that. Senator Guile?
Thank you very much, Madam Chair. Thank you for your testimony, and thank you, Dr. Brown, for your testimony as well. You said you were at U.S. Acute Care. Is that correct, Dr. Brown?
That's correct, U.S. Acute Care Solution.
Okay. I understand there's some sort of connection between U.S. Acute Care and U.S. Anesthesia Partners. Is that correct?
No, there's no connection. We're
Okay.
a physician-owned emergency medicine group. We are not directly connected with U.S. Anesthesia Associates. They are in support of these measures as well, though, I believe.
Okay. Okay. Were they founded by the same hedge fund? Is that accurate? I had some information about that.
I do not believe that's correct. I can
Okay.
get back to you on that.
Okay.
And
Are
we
you
weren't-
aware?
We were not founded by a hedge fund. We are a group of member emergency medicine organizations that have come together that are like-minded and remain physician-owned. We're not in private equity. Each of our providers has ownership stake in our group.
Okay. You said you're not private equity, so there's no ownership by any private equity firms by U.S. Acute Care? That's correct?
We're 98% physician-owned. We do have a loan with an investor, which provides us the equity for acquisition of the 10 emergency medicine sites that we acquired in the last year.
Okay. And so that loan, is that Apollo Global Management? Is that right?
Yes.
Okay. And it's my understanding U.S. Anesthesia Partners, they were involved in a lawsuit with the FTC regarding certain business practices. Do you have any information about that?
Again, I'm not with U.S. Anesthesia Associates. I'm with U.S. Acute Care Solution.
Okay, so you don't have any information about that FTC lawsuit?
I do not.
Okay. I also had some information that U.S. Acute Care, before the passage of the No Surprises Act, engaged in some balanced billing practices during reimbursement negotiations. Is that correct?
That is not a practice of our group. We have maintained in-network status, as I mentioned, with greater than 90% of our insurance partners. and in 90% in the state of Maryland.
Okay, all right. Well, thank you very much, Dr. Brown. I appreciate your testimony.
Thank you.
I do not see any other questions. We have 2 unfavorables. Thank you, Dr. Brown. Thank you, Senator.
Thank you.
We have Matt Celentano and Kimberly Robinson.
Madam Chair, members of the Senate Finance Committee, I am still Matt Celentano, still here on behalf of the League of Life and Health Insurers in opposition to Senate Bill 437. This legislation would do nothing except raise costs for consumers with zero benefits to them. It won't improve care. It won't streamline coordination. It purely picks winners and losers and how they are reimbursed by HMOs. The irony of this discussion is that the bill was offered by the ER docs, and then the MHCC interim studies show that they actually fare worse under this proposal. The whole point of an HMO product is that the consumer accepts a narrower network with the same rich benefit structure that you would get in a PPO product. This legislation threatens that choice. The MHCC work also supports this. HMO products by design, to create affordability, have narrower networks. As you all know on this committee, the No Surprises Act in Congress was passed to prevent providers from balance billing consumers for services provided in out-of-network settings. This bill seems to want to reverse engineer this consumer protection law by indexing the reimbursement rates to 2019, prior to the enactment of the No Surprises law. It's an end around on a significant piece of legislation from Congress to protect unknowing patients, and the impact of this legislation would result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. We thank you for the opportunity, and we are unfavorable on Senate Bill 437.
Good afternoon, Madam Chair. Kimberly Robinson for Care First Blue Shield, in respectful opposition to the bill. The sponsor of the bill talked about the fact that we do have 2 different formulas under our law. We do have one for out-of-network benefits under HMOs and one under PPOs. And while I understand the bill's intent to try to align those 2 formulas, they are different because these 2 products are different. And in fact, the reason why those laws came to be, they even came to be for 2 different reasons. And as Mr. Celentano talked about the impact and the significance of 2019 and the creation of the No Surprises Act is an important federal consumer protection when it comes to balance billing and out-of-network costs, that's actually the reason why the PPO formula came to be. That law came to be as Maryland was actually grappling with questions around assignment of benefits, which is a practice where that was designed to address actual balance billing that was happening most often in the hospital-based setting for members of your communities and our members, and how that was going to be addressed. And so there's a history for why the 2 formulas differ. There's a reason why there's a significant impact in changing the HMO law to meet the PPO law, and why that is going to have, without question, an impact on costs for Marylanders who right now won't experience anything different between the 2 laws other than the increase in the cost. And that is, in fact, a concern. I said it earlier today. I'm going to say it all the time on bills that increase premium. Affordability is the first step to accessibility when it comes to health insurance and the ability to help people access care through those products. And so I will yield my last 19 seconds. I will just second what Mr. Celentano said and request your unfavorable report.
Kimberly, can you give me an example? Like, I don't really understand what the issue is. So is this about someone going to the emergency room outside a network, or what? How does this involve? Thank you.
So the way the HMO law is set up, so let me actually take one step back. So one of the fundamental differences typically between HMOs and PPOs are the way your network is going to operate and the expectation of whether you're receiving in-network or out-of-network care. HMOs have a much more significant in-network expectation. The reason why consumers will pick a PPO, for instance, is because while there are preferred providers, there is in fact an out-of-network benefit. So when you choose to see an out-of-network provider, which is a choice you can choose to make, you know you're going to have a different cost share when that happens, right? You have a different out-of-pocket cost that's going to come along with that. HMOs historically have been built to really drive people into in-network care as a matter of managing cost. The one place where, as you've heard even from proponents of the bill, where you're going to end up seeing that out-of-network provider, regardless of whether they're in your network or not, is likely to be in a hospital. Because if you need acute care, you're going to go to an emergency room or you're going to go to the hospital and you're going to see whatever providers are there. You're not choosing the providers. You don't walk in the ER and say, I'd like to only see an in-network ER provider. Whoever is there is the person who is going to give you the good care that you need. And so when that would happen, the question was, how does the HMO then reimburse that out-of-network provider? And before, and it's funny for me to get to say this, but because I've been doing this for 22 years, before I was doing this, that HMO law was conceived of in order to set, at the request of providers, this formula to kind of give a certain way to calculate what that was. And because, again, we've got basically largely only in-network providers, it was built to have a relationship to what was happening in networks for what's happening out of networks based on that product design. Again, different than what happens on PPOs. The history on the PPO formula is different. The product operates different, and so that formula got conceived of differently than the one that's happening here. But there's a reason why a lot of this is focused, not exclusively, because the way the law is written, it does cover all out-of-network HMO services, and some products have more access in that space than others. But largely, hospitals are a big place where that may happen to a consumer.
Thank you. Are there any other questions? No? Thank you very much. That ends the hearing on Senate Bill 437. And I think we have one more bill. We do. And our last bill of the day is Senator Lamb's bill, Senate Bill 438, Pharmacy Benefits Administration, Maryland Medical Assistance Program, and Pharmacy Benefit Managers. It's Senator Lamb, and his panel is Christine Lee and Brian Hose.
All right. So good afternoon, Chair Beidel, members of the Senate Finance Committee, here to introduce and testify in support of Senate Bill 438. For the record, Clarence, I'm Senator District 12. So as background, currently our state Medicaid managed care organizations are paying our pharmacists at a rate that is extremely low. In fact, it is so low that it's actually costing the pharmacy to provide drugs to a Medicaid patient. Basically, they're losing money on filling out these prescriptions. The state currently, through its managed care organizations, is paying pharmacists less than 70 cents per prescription. This is in contrast to the $10 paid to pharmacists dispensing Medicaid fee-for-service patients. 70 cents per prescription is nowhere near enough for pharmacists to pay themselves, pay their rent, pay their utilities, pay the pharmacy techs, keep the doors open, overhead, and the like. This means that pharmacists must find some other streams of revenue, which takes the pharmacist's attention away from their core responsibilities, filling out prescriptions, or the pharmacy will have to close because it would be unsustainable to keep its doors open. Under this bill, Medicaid managed care organizations would be required to pay pharmacies the cost of drugs plus the Medicaid fee-for-service rate of about $10. Even that isn't necessarily enough to for a pharmacy to be able to turn a profit, but it will hopefully at least keep it afloat so that it can make it more affordable to run the pharmacy itself, so that it wouldn't have to close and leave its patients in the community without access to a pharmacist. Our current current managed care organization dispensing rates essentially assume that pharmacists are essentially like vending machines dispensing drugs and just kind of processing through scripts one after the other at very, very low, if any, margin to be able to continue to do so. This bill recognizes the important role that pharmacists play in our healthcare system and reflects that as well. I recognize that the bill has a significant fiscal note, but would like to draw attention of the committee to the language in the fiscal note that says the analysis does not consider the language in the bill that says that the bill does not apply to pharmacy benefit management-owned pharmacies like CVS. So there are some pharmacies that are PBM-owned, and this the fiscal note analysis does not consider the fact that it doesn't apply to those. So we believe that should significantly reduce the fiscal note. So I recognize that the note writers had limited data, but the exclusion of these large corporate pharmacies by this bill should cut the fiscal note significantly. And with that, I would appreciate the committee's consideration for a favorable report. Happy to turn over to other members of the panel to take any questions at the end.
Thank you, Senator Lamb. Thank you, Chairwoman Beidel and members of the committee. I'm Brian Hose. I'm representing Epic Pharmacies, also representing myself, a pharmacy owner in Western Maryland and Sharpsburg, and the other 200 independent pharmacy owners that Epic services in the state. Last year in 2024, we filled roughly 3,000 prescriptions for Medicare managed care plans, 5 of them in the state of Maryland. Of those claims, 57% of them were below our cost to acquire the drug. That's after any rebates or anything that we might receive. 92%, almost 93% of those were paid below my cost to dispense. When we pay staff, keep the lights on, put it in a vial, counsel the patient, all of the things that are mandated when we provide that service to a patient. That's an astounding number. That is higher than any other payer that we may say is a poor payer. These MCOs collectively are paying us well below our cost to provide that care. That resulted in a loss to the pharmacy last year just for these prescriptions, these 3,664 prescriptions of $26,428.98 that my small pharmacy in Sharpsburg has donated to the state of Maryland in their Medicaid managed care program. It's not something that can continue. We've already done what we can to reduce staff, decrease hours, cut free services, and decrease inventory to stay afloat. It is a challenging environment. You'll hear from the opposition that this will, inevitably raise costs. The fiscal note has been challenging. We still don't believe that the writers of those notes understand exactly how the costs are calculated. But what we have seen is in states that have done this, 16 states that have enacted Medicare managed care reform have saved over $1.9 billion in state dollars while paying pharmacies more fairly. We've seen, we can provide some of the data on that, but we've seen 12 states that have instituted an actual cost reimbursement mandate for Medicare managed care prescriptions, and that has saved $1.27 billion for those states. We urge you for a favorable report.
Brian, just a quick question, if I can. Was that 3,000 prescriptions, was that just your pharmacy, or that was all the Epic pharmacies?
That was just my pharmacy, and we're a relatively small, low-volume pharmacy. There are many that are much larger than us. You're talking thousands and thousands of those prescriptions across the state.
Oh, thank you. I just wanted to clarify that. Thank you. Christine?
Yes. Good afternoon, committee members and Madam Chair. My name is Christine Lee. I own a professional pharmacy in Rosedale, Maryland. And to echo Brian's point, so when we have below reimbursement, ultimately the patients are suffering. So this bill is not necessarily about reimbursing pharmacists and lining their pockets. It's more to the fact that I'll be able to continue providing services to patients. So my biggest budget item is definitely inventory. I spend just about $300,000 every 2 weeks to purchase the drugs that my pharmacy dispenses. I have a relatively moderate volume store. So if I can't pay my bills, I can't have the drugs. If I can't have the drugs, I can't dispense the drugs. So what drugs are we talking about? Diabetes drugs, asthma drugs, COPD drugs, heart failure drugs. So patient comes in, they can't get their product, they don't take the medication, and where do they go? The emergency room. So we talk about a fiscal note of being expensive, but you have to think about it on the other hand. If patients can't take drugs, then the emergency room visits go up and the hospitalization visits go up, and ultimately their care goes down. So that's one item for access. And the other is just typically pharmacies are closing. You don't need a Board of Pharmacy data report to look around the neighborhood. I own my pharmacy in Rosedale. I live in Bully's Quarters. In January alone, the CVS and the Walgreens on my way home have closed. I mean, so people can't pay for the workforce to provide the service. And really, again, it's really concerning with the access. So I urge you for a favorable report, and I can answer any questions at this time. Thank you.
Thank you. Do I have any questions of Senator Mount?
Thank you, Madam Chair. And for the witness, I'm sorry, I missed your name.
Brian.
Brian. Mr. Brian, I'll just say Mr. Brian.
Brian Hose.
The fiscal note says, I'd like to talk about the scenario where you described other states have implemented this and actually saved money, and the pharmacies have been able to cover their costs. The fiscal note says Medicaid expenditures, 50% general funds, 50% federal funds, increased by a significant but indeterminate amount, likely by millions of dollars in 2025 and tens of millions of dollars beginning in 2026. And the fiscal reports are really well done, and they're based off of, a scenario of situations or facts, the current. But can you explain to the committee how this has worked in other states where they've actually not actually spent more money, but saved money by implementing this change?
So I would agree with you that typically fiscal notes are very well done, but what we've learned over the years with this bill is that they don't understand how to calculate this cost. Right. We've seen that typically what they will do is take the increased dispensing fee and multiply it by the difference in what the previous dispensing fee was and get this astronomical number in the millions of dollars. What they would have to do to figure out the actual impact of this bill would be to reprice every single one of those prescriptions to what NADAC was on the day it was filled. I don't believe they're doing that. They don't necessarily have the ability to go back and look at every single, we're talking like millions of prescriptions that they would have to reprice to that NADAC rate and then add that greater dispensing fee. Mm-hmm. So where we believe the cost savings lies, and we've seen a lot of this within FTC reports that have come out recently, is that the PBMs, when they're able to force things to their mail facilities, are reimbursing them hundreds and thousands of times greater than what they should be reimbursed based on NADAC, which is the pharmacy invoice cost. It's a survey of pharmacies' invoice costs. So when you look at that and you're not taking into account those prescriptions that may be reimbursed at a much greater level than they should be, and also not accurately repricing every claim to NADAC, you're not getting the full picture of what that would do. These other states have been smarter in the way that they've looked at it, and they've realized significant savings when it's come down to paying pharmacies what their invoice cost is and a reasonable cost to dispense. It's completely transparent. There's no funny business with the PBM setting those prices. It is transparent cost and transparent cost to dispense.
And do they just implement this unilaterally, or was this something that was in existence in those states?
So different states have taken different approaches with it, and I can get you more information. We've got a document that lays out those very specifically, how each state has kind of tackled that, but there's several different approaches. Some have completely carved out PBMs and done fee-for-service Medicaid for all of these prescriptions. Some of them have allowed a single entity PBM and been very specific about how that will happen. But there's been lots of approaches to it. Some have just set a reimbursement floor like this bill tries to do, to say this is what you have to pay, to make it very transparent.
Thank you for your testimony.
Yeah, thank you.
Thank you, Senator. I don't see any other questions for this panel. Thank you all for your testimony.
Madam Chair, if it's okay, I'm going to step away to JPR because I have a bill hearing that I'm being told I should go up there for. So.
It's fine because the last one's an unfavorable and you don't want to hear it anyway.
Yes, I'm fairly certain I don't need to hear that one.
You can always go back and listen later, Senator. Thank you. Good luck.
I think I know what the opposition's going to say.
Thank you. It's Joseph Wynn, virtually and unfavorable. Mr. Wynn, you can begin.
Madam Chair, can you hear me okay? Excellent. Madam Chair, members of the committee, good afternoon. For the record, it's Joe Wynn. I'm the Executive Director of the Maryland MCO Association. Thank you for the opportunity to speak on Senate Bill 438. As you know, this bill is similar to last session's bill. I spoke on that bill last year, and our concerns remain the same. Maryland's MCOs provide comprehensive care, which includes prescription drugs, several branded drugs for the Health Choice members. And like other organizations that provide health benefits, such as self-insured employers, health plans, some labor unions, and even the state of Maryland The MCOs rely on PBMs to help control the rising cost of prescription drugs, and of course, also the full range of pharmacy benefit services that they provide to us. Our concern is that this bill would remove tools, negotiating tools from the PBMs, and has the result of increasing costs for prescription drugs in the Health Choice program. Madam Chair, the bill's older fiscal note was cited in my written comments. I do believe there was some updated figures in the fiscal report that was attached to the bill file. It's my understanding, though, that the numbers are still fairly costly and in the 70 million range in further out years. As a result, we respectfully request an unfavorable report on this bill. And I have brief remarks today. I'm the last bill, and I'm here to take any questions if there are any questions from the committee. Thank you so much.
Thank you, Mr. Nguyen. Yep, you're the last bill of the day, and it's 10:04. Last night it was like 6 o'clock. So I have one quick question. Did you hear the testimony for Brian Hose that in many instances they're making 7 cents profit on filling a prescription?
Yes, ma'am, I heard that. And I don't know how that works out for that particular pharmacy. The PBMs have a lot of different tools on which they use to negotiate drug prices on behalf of their clients. I don't know exactly what the arrangement is with that gentleman's pharmacy, though.
Well, I just have a great deal of concern about losing these smaller pharmacies, particularly that are out in rural areas where no other pharmacy really wants to be. We can't have these pharmacies continue to lose this kind of money every year. So there's got to be a solution. And I understand it might cost the state money, but on the other hand, we're losing these businesses, and that's not a good thing either. We have a question from Senator Mounts.
Joe, can you hear me okay?
Yes, sir.
So on the prior panel, Brian was testifying. I asked him a question about where this is in place, functioning in other states. I think a couple of them, New Mexico and Nebraska, are states where this is in place. How do the MCOs handle this there?
Senator, I don't know. I'm happy to try to find out. I don't have that much experience with those other states. I did hear the part of his testimony where he talked about savings to the states. That's a head scratcher. I don't understand how they could conclude that based on going from a very small dispensing fee to almost $10. I just don't see how the math works. But I'm interested to hear more about the analysis, and I'm happy to meet with them to discuss it. I'm not familiar with those other markets. Sorry.
Yeah, and that testimony wasn't a nuance. I can think of about 6 offhand small pharmacies that are really important in my district that tell me how much money they lose every year on this issue. And it's not $20,000. It's greater than that.
Senator, we're sympathetic. Of course, we rely on the independent pharmacists and all of the pharmacies that operate in the state of Maryland to have our networks for our members in Health Choice.
Well, I'd be interested to hear about those other states where this is occurring, where it's already in place, and how it affects MCOs and how it works there.
Senator, would you be willing?
You could share.
Can you repeat the states in question? I don't recall.
I know offhand too. I'll give you New Mexico and Nebraska.
Okay. Senator, I'll follow up with you.
Thank you.
You got it.
Thank you, Senator. Any other questions? Thank you very much, Mr. Nguyen, for being with us. This ends the hearing on Senate Bill 438 and ends our hearings for the day. Thank you, committee.
Yes.